Setelah video. Setelah video. Cek one, cek satu. Oke. Masker. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Selamat pagi dan selamat datang kepada yang saya hormati, para pembicara dan moderator yang telah hadir di RSCM Kirana, Kepala Departemen Mata FKUI RSCM Kirana, dan seluruh staf Departemen Mata FKUI RSCM Kirana, serta seluruh rekan-rekan sejawat dokter spesialis mata dan residen di seluruh Indonesia. And also we would like to welcome our honorable speakers from National University Hospital Singapore, Dr. Gangga Darasundar and Dr. Anatan. Also we welcome our attendees from Singapore and other countries. Selamat bergabung pada seri kedua dari rangkaian RSCM Kirana-NUH Collaborative Webinar Series. Sesi ilmiah pada hari ini akan terbagi menjadi dua bagian, yaitu sesi pertama tentang kornea dan kelainan eksternal mata, corneal and external eye diseases, yang akan dilanjutkan sesi kedua tentang tumor permukaan okular, ocular surface tumor. Hadirin sekalian, acara webinar ini akan dimoderatori oleh Dr. Siska Widiawati, spesialis mata konsultan, dan kemudian oleh saya, Dr. Hisar Daniel, spesialis mata. Ladies and gentlemen, we will begin our webinar, and the first session will be hosted by Dr. Siska, and the second session will be hosted by me, Dr. Hisar Daniel. Before I hand it to Dr. Siska, I would like to share a quote from Benjamin Franklin. Tell me and I forget. Teach me and I may remember. Involve me and I learn. So I encourage all participants to involve in discussion through Q&A section. Thank you for your attention. Kepada Dr. Siska dipersilakan untuk memandu sesi pertama.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi. Good morning to all speakers and also our participants. Thank you for joining us again today. My name is Dr. Siska and I will be the moderator for this morning session. The first part, this morning sessions will be cornea and infection session, and we will have three speakers, Dr. Lukman Edward, Dr. Farah Bimarta, and Dr. Anna Maritan from NUH. And after three presentation, we will have discussion afterwards. And please, the participant can write down questions in the question and answer box. You can type it in Bahasa or in English, as you wish, whichever you feel suitable, and we will ask those questions to the speakers. And I would like to remind you, in order to get certificate, please fill the Google form in the post test at the end of the session. So let's start to the first session. Please let me introduce our first speaker first. We will have Dr. Lukman Edward, specialist mata consultant, our consultant in infection and immunology in the Department of Ophthalmology, Cipto Mangunkusumo Hospital, Faculty of Medicine, University of Indonesia. He has fellowship in ocular infection and immunology in the Department of Ophthalmology, Rumah Sakit Cipto Mangunkusumo, Faculty of Medicine, University Indonesia, and also fellowship in uveitis and medical retina in Hospital University Kebangsaan Malaysia, Eye Center in Malaysia. He is a member of Indonesia Ocular Infection and Immunology Society in the Persatuan Dokter Spesialis Mata Indonesia, and also member of International Ocular Inflammation Society. So I give the stage to Dr. Lukman to start his presentation. Please, Dr. Lukman.
Okay, thank you, Dr. Siska. Assalamualaikum warahmatullahi wabarakatuh. Good morning to all participants. And also thank you for the committee that give me the opportunity to share. And I will talk about the limbal stem cell deficiency. By definition, limbal stem cell deficiency or LSCD is a condition which there is a deficiency of stem cells that resides in the cornea scleral junction in the palisades of fog. The stem cell itself is very important for our corneal hemostasis and reparative process of the corneal epithelium. The etiology of the LSCD could be autoimmune, such as Stevens-Johnson syndrome or toxic epidermal necrosis, ocular cicatricial pemphigoid, chemical or thermal injury, and also it is common in our country that we also have patients with LSCD with the experience of extensive corneal or ocular surface infection, such as corneal ulcer. And some of them also have like allergic conjunctivitis, atopic or venal keratoconjunctivitis. And some of them also have the rosacea. The LCD itself can happen in as a congenital disease like an iridia or ectodermal dysplasia, and patient with a history of limbal tumors, and patient who suffer with multiple ocular surface surgeries like a pterygium. This is the management algorithm for the limbal stem cell deficiency. In the acute stage, usually we can treat patient with the topical steroids and with the adjunctive treatment like topical lubricants, or maybe in the beginning we also can do the surgery like amnion membrane transplantation. In the chronic stage, whether patient have unilateral or bilateral, in the unilateral partial, so we can treat patient with the LCD with the conservative management, and then we also can give patient with the soft contact lens or amnion membrane transplantation. In the diffuse unilateral or bilateral, we can do the surgery such as like conjunctival limbal autograft or simple limbal epithelial transplant or cultivated limbal epithelial transplantation, whether it is allogenic or autogenic. And keratolimbal allograph. Yeah, so we can get it from the cadaver. Before surgery or after surgery, for the to optimize the ocular surface health. So
slide looks not very clear to the audience. Perhaps we can restart screen sharing now.
Okay. I can continue. To optimize the ocular surface health, so you can give patient with the very frequent preservative-free artificial tears. Yeah, I choose the preservative-free for these lubricants. And then long-term preservative-free topical corticosteroid, if it's necessary to control the ocular surface inflammation, or other immunosuppressive drops or ointment, such as cyclosporine or tacrolimus. This is our experience in the Cipto Mangunkusumo Hospital, Kirana. I collect 5 years retrospective study from 2015 to 2019. Actually, we already performed more than 13 patients with the LCD. This is, I will report the 13 patients, 9 female and 4 male with the average 35 years old with the range of 18 to 70 years old. 10 patients have bilateral in rosacea, vernal keratoconjunctivitis, Stevens-Johnson, and ocular cicatricial pemphigoid, and 3 unilateral because of the chemical injuries. All of this surgery, we perform keratolimbal allograph. This is the technique we perform, so we can get the donor from the cadaver. So the remaining corneal scleral rim, and then we section in equal halves usually, and then with the Westcott scissors used to dissect the peripheral excess scleral tissue. So we can take it 1 millimeter from the limbus to the cornea and 1 millimeter to the sclera. So we can get 2 millimeters. And then the posterior half of each secretion, like posterior stroma, descemet membrane, and endothelium, video. So the recipient, we perform the limbal peritomy 360 degrees, and then we excise the limbus. Usually we divide into not 180 degrees, but 160 at the superior and inferior with the approximately half thickness of depth limbus and the sclera. And then abnormal fibrovascular panus and epithelium are removed. And then we put the 2 crescents to the superior and inferior side, and the gaps of the between this graph is left to allow conjunctival cells to repopulate the corneal surface. And then we put the amnion membrane above the cornea, and we suture with the nylon 10O, and then at the end we cover with the soft contact lens. So this is the result for the visual acuity. Before the surgery, 1 patient with the visual acuity is 660, and then 3 patients with 360, and 2 patients with 1 meter counting finger, and mostly of them with the visual acuity hand movement. And then after surgery, we still have 4 patients with the hand movement and counting finger visual acuity, especially in patients with history of Stevens-Johnson syndrome and chemical injury. But most of them can reach the visual acuity 7.5 to 660. This is the example of the first case, male, 35 years old with blurred vision on the right eye since 1 year. And patient also has history of the repeated right eyes, watery, and usually treated with steroid several times if he came to the ophthalmologist. And patient also have ocular allergy since childhood. And then the left eye also had similar experience, but better than the right eye. So we diagnosed this patient with the chronic allergy conjunctivitis and limbal stem cell deficiency on the right eye and corneal scar on the left eye. So in this picture, we can see the cornea covered with the neovascularization and the conjunctivalization. The visual acuity before surgery is hand movement, and we perform the keratolimbal allograph, and then also with amniotic membrane transplantation. And then the visual acuity 3 years after surgery and after cataract surgery can reach the 6.9, and it is still 6.9 at the last follow-up years ago. The second case, a female 13 years old with a history of recurrent red eye, and then no history of trauma, contact lens wearing, and systemic disease, and also no history of allergic. So we diagnosed patient with the rosacea keratitis, and then we gave patient with the teramycin ointment and lubricant eye drop. In this picture, we see the visual axis still clear, but unfortunately, after 2 years, it is covered with the neovascularization and the conjunctivalization. This is the right eye and the left eye. So we performed the surgery on the left eye first on June 2016 with the keratolimbal allograph, and then the right eye on the 2017. Unfortunately, the patient can reach visual acuity 6.9 and 7.5 after 1 year surgery. Patients not stay in Jakarta, but in other cities. So she came every 3 months or 1 year. The second case, this is the older woman with the recurrent red eye, both eyes. And then the visual acuity 630 and on the both eye. So in this picture, we see the neovascularization, epitheliopathy, and some of them also have corneal defect. And maybe this is also have the infiltrate. So we diagnose this patient with limbal stem cell deficiency. And it's getting worse. And then the first surgery we perform on the left eye. But unfortunately, the visual acuity on the left eye is still 560 because of the corneal scar, and then also patient have immature cataract. Most of them, we manage with the amniotic membrane transplantation after keratolimbal allograph, and we suture with the nylon 10O as adjunctive procedure to reach the high success rate. And then some of them also we inject the antivascular endothelial growth factor once or several times to reduce the neovascularization. For the local immunosuppressive treatment, we give patient the cyclosporin A drop and then tacrolimus ointment. In Jakarta, we don't have tacrolimus eye ointment, so we treat it with the tacrolimus ointment 0.03%. This is for skin actually. Yeah, the corneal neovascularization itself, actually this is can give the poor result if we don't manage it properly. This is characterized by the invasion of new blood vessels into the cornea from the limbus, and then the new blood vessels can lead to the lipid exudation or persistent inflammation and scarring. So in this picture, we see the patient with the corneal neovascularization, and we inject it with the anti-VEGF, and also we perform the argon laser. So at the end of this treatment, so we can see the lipid exudation on the central cornea. The corneal neovascularization itself can happen in the inflammation, patient with trauma injury or chemical burns, bacterial and viral infection, and then also like systemic, like Stevens-Johnson syndrome or ocular cicatricial pemphigoid. So for this condition, usually we treat with patient with the injection of anti-VEGF and then laser photocoagulation. Actually, in limbal stem cell deficiency, we still face the challenge to treat it. So how we can get the cornea can become clear? Maybe we need also two-step surgeries. So we start with the limbal stem cell graft, and then we perform the keratoplasty, such as our third patient, the older woman. So because of the corneal scar in the central visual axis, so we can perform the keratoplasty after the limbal stem cells become better. So the primary failure on the limbal stem cell management, if we see the absence of primary corneal epithelialization with progressive epithelium loss, and then we also see the conjunctivalization over the peripheral cornea. And this here is the some of the risk factors, because for the limbal stem cell graft failure, like dry eye, symblepharon, chronic inflammation, lid abnormality, and Stevens-Johnson syndrome. So I will present the fourth case, patient with the Stevens-Johnson syndrome, 19 years old female with history of recurrent dead eye on both eye. So patient have history of Stevens-Johnson syndrome 2 years before. And then the visual acuity on both eyes, 2 meter counting finger. Patient also have entropion. So after we perform the keratolimbal allograph, we also perform the cataract extraction. But neovascularization still persists, whether we perform bevacizumab injection subconjunctivally several times, and then cauterization for the feeding vessels, and then final visual acuity still hand movement. So this is our fourth patient with a history of Stevens-Johnson syndrome. So for the last, the limbal stem cell deficiency management is still a challenge for ophthalmologists. All surgical technique can provide good result when supported with good therapy. In our experience, keratolimbal allograft technique can give good results. And Stevens-Johnson syndrome is still a challenge. So perform the keratolimbal allograft and followed with optical keratoplasty may be able to give good results. Thank you.
Thank you, Dr. Lukman. That was a very great presentation. You have a very many successful cases with external eye disease. Actually, well, we should move to our next presentation. I would like to invite Dr. Farabi. Dr. Farabi Marta, allow me to introduce first. He is one of our new member in cornea and refractive surgery department. He is one of our consultant now in cornea and refractive surgery division. He has a fellowship in cornea and under segment disease in Hatam Al-Anbiya Eye Hospital in Masad, Iran. He is now the head of cataract blindness handling section of Perdami Jaya. He is also a member of cataract blindness handling section in Perdami and also a member of Indonesian Eye Bank, and also a member of Indonesian Society of Cataract and Refractive Surgery of Perdami, or SCRS Perdami. Also a member of Asia Pacific Association of Cataract and Refractive Surgeon, or APA-CRS, and also a member of European Society of Cataract and Refractive Surgeon, or ESCRS, and also a member of Asia Cornea Society, or ACS. I will give Dr. Farabi, please, you may start your presentation.
Thank you, Dr. Siska, for the introduction. Assalamualaikum warahmatullahi wabarakatuh. Good morning to all professor, doctor, and consultant. This morning, I would like to present my presentation with titled Management of Descemet Membrane Detachment with Intracorneal Hemorrhage. I will divide my presentation into 3 sections. First, we will talk about Descemet Membrane Detachment, or DMD. Second, we will talk about Hemorrhagic Descemet Membrane Detachment, or HDD. Finally, we will close this presentation with interesting case of management of HDD with venting incisions. Descemet membrane is part of our 5 layer of the human cornea. It is actually the basement membrane of corneal endothelium. It is An elastic and strong membrane consists of collagen type 4, 8, and glycoprotein. As we know, endothelial cell is one of the most important layers in our cornea. It has various pump mechanisms that keep our cornea relatively dehydrated and can keep transparent. So the function of Descemet membrane itself is to keep the endothelial layer in place to maintain corneal physiology and clarity. If Descemet membrane detached, the cornea will become edema. From anatomical view, the Descemet membrane consists of two layers. The first is the outer non-banded layer, which is actually the substrate of endothelium, and the second one is inner banded layer. Above the Descemet membrane, there are newly invented layers called Duas layers, although this is still controversial. Above the Duas layer is the corneal stroma. The Descemet membrane attached loosely to the stroma with fibronectin. Therefore, in this picture, we can see two potential intracorneal cleavage plane. First, between the Duas layer and the stroma. The second one is between the Descemet membrane and the Duas layer. As we can see in this picture, there are two spaces. Number one is between the Duas layer and the stroma. Number two is between the Descemet membrane and Duas layer. Fortunately, number one space is only relevant for lamellar corneal surgical procedures, such as big bubble type 1, deep anterior lamellar keratoplasty or DALK, or donor preparation in predescemet endothelial keratoplasty or PDEC. The most common site for happening the DMD or Descemet membrane detachment is space number 2, the space that also we know as pre-Descemet space or supra-Descemet space. Descemet membrane detachment can happen because of ocular surgery, trauma, or spontaneous. It happens in 2.5% of cataract extraction, with the most common procedure is SICS. It can happen because of various steps, including improper insertion of the instrument through the incision or inadvertent injection of OVD or fluid. There are no international standard for managing the Descemet membrane detachment have been published, but Kumar et al. Proposed a simple algorithm based on anterior segment OCT image. He called this algorithm as HELP, stand for height, extent, length, and pupil. The pupil divided by zone 1, 5 mm central, zone 2, 5 until 8 mm, and zone 3 more than 8 mm or peripheral. In this algorithm, the surgical intervention only performed if the height is more than 100, length more than 1 mm, or in central area or zone 1. And also for the Descemet membrane, which is already widely like more than 300 micron. In the other categories, we can still plan for medical management, and if there are no resolution within 4 weeks, we can consider the surgical intervention. Another simple classification proposed by Jain et al. He divided into 3 sections: mild, less than 25%, moderate, 25 until 50%, and severe, more than 50%. The treatment only performed in moderate and severe cases, and Asia et al. Added the one DMD type that have to be directly perform surgical intervention, like the scrolled DMD or visually impairing DMD. We have to realize that even we do surgery in these patients, there are risks of repeated surgery in 15% of cases. So we can conclude that the management of DMD itself consists of two things, the medical and surgical. The medical, we can give hyperosmotic agents and topical steroid. In the surgical, we can stitch the descemet membrane detachment with nylon 10 or sutures or give OVD. And the most common surgical intervention is anterior chamber gas injection or pneumatic descematopexy, either using air, sulfur hexafluoride, or perfluoropropane. But we have to be careful to using this type of gas since it can make endothelial toxicity and also pupillary block. And if these two modalities fail, consider to perform penetrating keratoplasty, dissect, DMEC, or PDEC. Now we proceed to the hemorrhagic descemet membrane detachment. What is the difference between the HDD and regular DMD? The first one, of course, the content of HDD is blood, the blood in the predescemetic space. The anatomical features, the blood itself can be trapped in the descemeted space without connection to the anterior chamber. So the management, first we have to drainage the blood, then perform the descematopexy. Meanwhile, in descemet membrane detachment, we can directly perform descematopexy. The complication of HDD is more severe since it can make persistent scar, and also the prognosis is more worse since it might take years to resolve. So this case presentation is intended to describe a case of hemorrhagic descemet membrane detachment or HDD and to discuss its management using corneal venting incisions. This is interventional case report. 84-year-old man with renaissance cataract performed SICS in another hospital. Unfortunately, he got nucleus drop, as we can see in this ultrasound picture. And he referred to our hospital and performed vitrectomy, endofragmentation, and endolaser. The patient left aphakia. 2 months later, this patient performed secondary implant with artisan iris claw IOL prepupillary, and intraoperatively the surgeon removed sutures in the superior part of the cornea from past surgery. Beside the sutures, there are intrastromal corneal neovascularization. So one day post-operative, we can see there are hemorrhagic descemet membrane detachment in this patient. This patient also have diabetes, hypertension, prostate hyperplasia, and take anticoagulant medication. From slit lamp examination, we can see the space between descemet membrane and the stroma was filled with whitish fluid in the superior part and with the blood in the inferior part. I presume that this blood going down because of the gravity. So we plan to do venting incisions and air descematopexy in this patient. This is the video of the surgery. First, we make step incision in the center of hemorrhagic descemet detachment. We step partial thickness perpendicular to the cornea. I make 5 steps in the surgery. Then we make full thickness paracentesis to the anterior chamber. Then we fill the AC with bubble using the cannula. This bubble will make the increase in intraocular pressure and also form the anterior chamber. After that, applying gentle pressure with a 2 spatula on anterior surface of the cornea to evacuate the blood. This gentle pressure or counter pressure is intended to first to increase the IOP, so the blood will come out. The second one is to increase the venting incision lips, so the blood itself can come out smoothly to the external surface of the cornea. We do not perforate the descemet membrane, so the blood did not come in to the anterior chamber. Then we swab the hematome from the peripheral border of the HDD to the direction of central or to the direction of venting incision. Same process repeated 360 degrees until all hemorrhage drained. After that, we give a full anterior chamber air tamponade or bubble and wait for 10 minutes. Then we change some of the bubble to prevent the pupillary block glaucoma. At the conclusion of the case, we leave the venting incision. No need to stitch or perform stromal hydration because we still need that for evacuate the blood. Then patient educate to supine position for 24 hours to facilitate reapposition of the separated descendant membrane and endothelial layers to the stroma. Surgical pause during this surgery is number 1, air bubble provide counter pressure against HDD and stabilize the globe. Step in the center of the HDD, which has highest predescendant space. Do not perforate the descendant membrane. Keep the blade perpendicular to the cornea, make deliberate cuts, and stop once the blood has come out. Two-handed spatulas make the counter pressure to redirect the blood clot to the vein incision. Air deshematopexy is a must. At 1 month follow-up, the visual acuity becomes 6/30 and corneal blood staining was slowly resolving. The anterior segment OCT 1 day post-op, we can still see slightly descendant membrane detachment, but without blood. In 1 week post-operatively, the descendant membrane detachment already reattached completely. And also we can see the corneal thickness reduced from 700 to 670 in 1 week. Hemorrhagic descendant detachment prevalence is quite rare, about 1 until 3% in glaucoma procedures. It can happen because of traumatic or spontaneous rupture of intrastromal corneal neovascularization. As we can see in this case, it also reported in some case of alkali burns and glaucoma procedures. The management of HDD consists of conservative treatment and aggressive treatment. Means we have to drain the blood. Drain the blood, we can perform up internal approach using the descendant membrane membranotomy, either with surgical or laser, or up external approach with venting incision like presented in this case. And then we perform air deshematopexy. There are some other reports that use BSS washout of hematome from pre-descemetic space, but we have to be careful to do this because they are potentially enlarging the detachment. And also there are reports about using of tissue plasminogen activator to lysis the blood clot intra pre-descemate space. HDD complication consists of corneal edema, persistent blood staining, angle closure glaucoma, and irregular astigmatism like in this picture, and it can be happen within 1 week. So we have to take these pathologies seriously and aggressively before its complication happen, because if there are already complication happen, there are possibilities of this patient that he need keratoplasty. Corneal venting incision is preferred rather than membranotomy because venting incision can perform early, no need to wait. Because in membranotomy, usually we need to wait until the blood clot because it is very difficult to laser the mobile descendant membrane. So we will wait until the blood clot is fixed. And the venting incision can also preserve the integrity of descendant membrane. And we can extend the incision. Like in this case, we make 5 venting incision. And no blood or fibrin and or other materials going into anterior chamber, so the inflammation will be minimal. In this fashion, venting incision is a good option. As a summary, HDD is a rare complication. However, the occurrence of it can be very morbid. Corneal venting incision has the benefit of preserving the integrity of the cement membrane, thereby decreasing the likelihood of further endothelial surgery. Corneal venting incision with air tamponade is the treatment of choice in HDD. Thank you.
Thank you, Dr. Farabi. That was a very great presentation and a very good case as an example. So let us continue to our next speaker, our distinguished speaker, our friend from NUH. I believe she's already in the speaker room. Dr. Anna Maritan. Allow me to introduce Dr. Anna Maritan to our audience first. She is a senior consultant from National University Hospital, Singapore. She is the head of Cornea and External Eye Disease Department of Ophthalmology in National University Health System, Singapore. She is also the head of Refractive Surgery Service Department of Ophthalmology, National University Health System, Singapore. She is the Program Director of Ophthalmology Residency Program of NUH, Singapore, and also as an Assistant Professor in Ophthalmology of U Loon Lee School of Medicine, National University of Singapore. Please, Dr. Anna, we would like to invite you to the stage to give your talk. Please, Dr. Anna.
Okay, all right. So I hope all of you can hear me loud and clear. My name's Anna. So I'm basically the head of Cornea Service in NUH, and it's my great pleasure to share with you basically my talk on advances in cornea transplant surgery. So in the last basically 2 decades, there's been quite a lot of advances basically in cornea transplant surgery. So I'm going to basically go through that with all of you. Let me see. Okay, so just a reminder to basically the trainees and the residents that's watching this program that the cornea is not just a transparent dust cover the eye that serves a barrier function. It is also the refractive surface that contributes 2/3 of the total power of the eye. And in order for the cornea to be clear and transparent, all right, so this function is largely comes basically fluid from the stroma into the anterior chamber, and in a smaller part by evaporation of tears from the surface of the cornea. So when do we have to do a cornea transplant? So well, other methods basically of restoration of the function of the cornea is no longer possible, then we go on to a cornea transplant. For instance, if you look at the photo on the left, right, if you have a corneal perforation that's too large to be sealed with cornea gluing, or the one in the middle where you have, let's say, a corneal scar involving the visual axis after infective keratitis and the vision cannot be improved by glasses or contact lenses. And also in the last photo on the right where you have basically pseudophakic bullous keratopathy, where your hypoosmotic agents cannot basically reduce the edema for the patient to have the vision function restored. For basic trainees that are taking exams, I would still want you to basically go through the indications of cornea transplants as follows: optical indications, tectonic indications, therapeutic indications, and others, mainly cosmesis. So the types of cornea transplant, I think when I first started my training about 20 years ago, the only type of transplant that was done with any frequency was actually a full thickness transplant, also known as PK, penetrating keratoplasty. And when I started my fellowship, we started to get exposed as well as I do basic partial thickness transplants, also known as Lamellar keratoplasties. This can be subdivided into the anterior part, which you transplant basically a cornea up to Descemet's membrane, salt or DALC, or the posterior part where you basically replace the Descemet's membrane endothelium, also known as endothelial keratoplasty, for instance, DSEC, DMEC, and nowadays PDEC. So this is the approach to basically a cornea transplant. If you have a patient with corneal opacity and they have no other ways of improving the patient's visual function and have to do a transplant, then the first thing to look at is where is the level of the pathology. If obviously the cornea is involved through all the 5 layers of full thickness pathology with poor endothelial function, then you go on to basically the traditional penetrating keratoplasty. If the patient has good endothelial function and basically the opacity is in the stroma above the Descemet's membrane, then you do anterior lamellar keratoplasty depending on the depth basically of the opacity. And in cases where you have basically poor endothelial function, then you perform endothelial keratoplasty. If if the cornea has been swollen for a long time, they can develop significant anterior stromal scarring. And in those cases, you might still have to do basically a full thickness transplant. With no significant stromal scarring, then basically an endothelial keratoplasty in the form of DSEC, DMEC, or PDEC basically will do the job. So just a short note on penetrating keratoplasty. This is something that all of us are very familiar with. Just a reminder to basically the residents and trainees watching basically this presentation that you always prepare the donor cornea before you deal with the recipient bed. Okay, this is basically for reasons that I will basically elaborate later. And in cases where the eye is very soft, for instance, post-vitrectomy, post-basic trauma, or in pediatric cases, a pharyngeal ring to stabilize the globe will help to prevent collapse of the globe during basic recipient dissection. I like to use basically RK markers to help me basically place marks on the cornea so that I know where to pass my sutures and to help me control astigmatism after the transplant. So after I prepared the donor cornea, which is usually typically oversized by 0.25 to 0.5 millimeters, you then deal with the recipient bed. You can do a full thickness or partial thickness trephination, right, followed by penetration of the globe. I still like to do my penetrating keratoplasties under general anesthesia because of this open sky basic stage where you can have basic expulsive hemorrhage. And that is why you need to have your donor cornea ready before you remove the recipient's cornea. And basically it's a direct replacement basically of the clear donor cornea onto the recipient bed, and you can use basically interrupted or continuous running sutures depending on basically what gives you better results. I'll now go on to anterior lamellar keratoplasties. So this is basically for replacement of diseased corneal tissue up to the level of the Descemet's membrane. It allows for preservation of the posterior stroma, including endothelium. The advantages being that it reduces the risk of endothelial graft rejection, and the risk of basically rejection in anterior lamellar keratoplasty is a lot lower than basic penetrating keratoplasty. It also allows for basically the structural integrity of the eye to be retained during the surgery itself, so that you do not have really an open sky basically part where there's a risk of expulsive hemorrhage. It also reduces the risk of endophthalmitis, peripheral anterior synechia, because you have not entered basically the anterior chamber. It also retains the structural integrity after the surgery, so that you do not have a situation where your patient with a penetrating keratoplasty falls down, hits the eye, and the whole graft falls off. And that is really basically really bad for the eye. With the correct basic technique and instrumentation, the visual outcomes of anterior lamellar keratoplasty can be comparable or sometimes even superior to that of penetrating keratoplasty. So the types of anterior lamellar keratoplasty, depending on the level of the lesion, it can be superficial, right? If let's say your lesion basically is in the top like 300 microns of the cornea, it can be microkeratom assisted or femtosecond assisted basic procedure. For instance, in this case where you have granular dystrophy, you can consider basically doing a SALK or SALK if basically the opacity is in the superficial part of the stroma. In other cases where basically the opacity is deeper, then you do a DALC or deep anterior lamellar keratoplasty. There are various techniques that have been described basically to do a DALC. I think most of us will be familiar with manual dissection, open or closed dissection. Other methods are Manley's technique of replacing basically anterior chamber with air bubble to increase visualization. What has gained popularity basically in the last 2 decades is the Anwar big bubble technique, all right? And also in the last decade, femtosecond laser assisted DALC. So this is basically DALC is suitable in procedures in basic conditions like keratoconus, like you can see in this case, where basically you want to remove as much as possible of the diseased basically stroma. This is some photos of basically SALC, superficial anterior lamellar keratoplasty. It is really simple to do. What you need to have is basically ALTK set, and you use basically the microkeraton to create basically a free cap instead of a LASIK flap. Obviously, pre-operatively, you will need to measure the level of basically the depth of the opacity and ensure that basically at the end of basically removal of the free cap that your bed, basically your recipient bed is smooth and clear and there's no remaining basically stromal opacity. Then what you do is basically mount the donor cornea on the artificial chamber and use the same microkeraton to create the same thickness cornea donor and just basically replace that onto the recipient bed. In basically, if the cut is the depth of basically the donor cornea lamellae is less than 12 microns, I tend not to use sutures and I just basically put a bandage contact lens on the surface. If it's deeper than that, I tend to basically use sutures. So this, instead of using a microkeraton, you can obviously use a femtosecond laser to basically perform this step. This is basically the big bubble technique that's been, that has basically improved the outcomes of basically deep anterior lamellar keratoplasty and is a procedure that is widely done by cornea surgeons now throughout the world. So the idea is to basically create basically an air bubble, right, to cleave between the stroma and the Descemet's membrane. This is actually a pre-existing layer of weakness that was mentioned previously. And what you do is basically after the lamellar dissection of a superficial layer of cornea, put in basically a blunt air cannula and inject air forcefully, which will then track along the natural plane of weakness between the stroma and the Descemet's membrane and create basically a space, an air space, to push basically the recipient's Descemet's membrane and endothelium away. And what you do after that is to penetrate this pocket and remove the remaining stroma. So you can see in the photos below, basically the formation of a type 1 bubble in basically DALC. So I'm now going to just show you quickly basically a big bubble DALC procedure. So the first thing you do is to determine basically the cornea size of the recipient. This is a basic case of a keratoconus that I'm doing basically a deep anterior lamellar keratoplasty for. All right. I'm just marking the center of the cornea, pre-placing basically the suture marks, doing a partial thickness trephination up to basically 70–80% of the thinnest part of the cornea, lamellar dissection of the superficial basic cornea off manually, right? I like to do basically use the close basically dissection technique so that I can actually see my level of dissection clearly. Right, so this step basically should be quite fast, right? If you're an experienced cornea surgeon, just keep in the same level, all right? And this is basically after you remove the first layer, right? Then what I do next basically is do pachymetry, determine the residual the thickness. And this is how I raise a big bubble. I use a 27 gauge needle to create a track, bubble down, followed by basically cannula. The DALC cannula I'm using now is a Fogler DALC cannula, and you can see the type 1 bubble forming up, all right, nicely. Okay. Create a paracentesis to lower intraocular pressure, deflate the bubble, and then basically remove the remaining stroma carefully. At this stage, if the eye is soft and done the paracentesis and the eye is soft, the risk of actually perforation is pretty low, but you still have to be very careful and not pull very hard on the remaining stroma because that can still cause an intraoperative basic Descemet's membrane penetration, perforation. So I like to basically divide the remaining stroma into 4 quadrants and then remove it, right? Okay, so this is just me removing all the 4 quadrants, remaining stroma, and then after that suturing the donor cornea into place. You can use basically continuous sutures or basically interrupted sutures, really up to you. Basically, it's really the surgeon's choice. You know, what gives you better basically outcomes, right? And this adjusting, basically bearing the knots and then adjusting the suture tension, checking with an intraoperative placido disc to make sure that my sutures, the tension is equally distributed. And after that, basically subconjunctival antibiotics and a soft contact lens. All right, so I'll skip that. So if you have basically access to a femtosecond basically laser, you can use the femtosecond laser, right, to basically do a femtosecond laser assisted big bubble technique, right, big bubble dart. So instead of doing manual trephination, you just apply the femtosecond by basically your standard big bubble technique, right? The other way of using the femtosecond laser is basically you use the femtosecond laser to basically do the entire surgery, but basically the level of your cut will be pre-decimatic, right? So the advantage of basically using the femtosecond laser is that you can create different configurations of the edge of basically your incision, so that you can create basically the two common configurations that are very that well used, the zigzag configuration or the mushroom configuration, so that the donor basic cornea can sit in the recipient bed in basically a more opposed version, more opposed fashion, and basically the wound closure will be basically better, and you have a much better basic cornea topography and contour after the surgery. The disadvantages of anterior lamellar keratoplasty is that you can still have residual corneal pathology, especially if you did not image and determine the depth of basically the corneal opacity well enough preoperatively. You can have recurrence of disease, for instance, like in renal dystrophy, lattice dystrophy, interface haze and scarring, epithelial ingrowth, and obviously you can see that basically the techniques can be equipment intensive, and honestly, it is technically challenging, and there's a steep basically learning curve in deep anterior lamellar keratoplasty. So I'll now move on to basic endothelial keratoplasty. All right. So EK, indications for EK, the two most common indications are pseudophakic bullous keratopathy, as well as fused endothelial dystrophy. But obviously, you can use it for other forms of corneal decompensation, including basically eyes and chat. So EK has basically evolved a lot in the last basically 2 decades, starting with DLEC, described by Terry in 2001. This is a really difficult basic technique, basically lamellar endothelial keratoplasty. And luckily, Price in 2005 modified and came out with the DSEC technique, basically Deshmi stripping endothelial keratoplasty. And 2006, a year later, Melis described the DMAC technique. And I think these are all basically whether you do DSEC, DMAC, or even the latest PDAC that's been described around like 2010, 2012, right? These are all very good techniques, and it allows for basic replacement of just the disease basically endothelium. So this is basically some photos showing the cardinal steps of basic endothelial keratoplasty. So you have to remove the donor's basic decubitus membrane and endothelium. You can do this under air or viscoelastic. And then after that, basically use an ALTK set to cut your donor cornea into 2 halves. Basically, this is actually DSEC. So you cut basically a donor cornea into basically the anterior stromal, the anterior cap, which you discard, and then the posterior lamellae, which you then use for the transplant. There are various ways of basically getting the posterior lamellar graft into the cornea. So various techniques as well as various insertion basic methods. The one that I use here basically is the Tan endoglide, because I was taught by Professor Donald Tan. And I find that this allows for a closed system of insertion of the posterior lamellar graft, and it's very comfortable and easy technique to use. At the end of surgery, inject a full air bubble to basically support the graft and float it up, the donor graft against the recipient basically cornea, and posture the patient for at least basically, I would say overnight, so that basically the donor cornea will get attached to the recipient bed. And this is a photo of the patient in the first day post-op with a fully attached basically DSEC graft and the residual small air bubble. I'll just quickly show basically a DSEC procedure. This is actually a phaco DSEC. So just determining the size of the donor cornea doing a conjunctival paratomy. Using a TUN endoglide in this case, so basically the scleral tunnel they're going to create is a 4.5 millimeter scleral tunnel. Okay, so this is partial thickness basis scleral dissection into the grain line. All right, and then you just carry out basically standard basic fecal emulsification. So I use basically my cataract surgery incision through the same incision that I use for the DSEC graft, right? Just doing basic standard cataract surgery, right? Lens insertion, and then followed by desomethorexis with a reverse Sinski hook. I like to use viscoelastic for this procedure because it keeps the anterior chamber nice and deep. And for this step, it's crucial that you have to remove the recipient's Descemet's membrane endothelium cleanly without leaving any text, because that will prevent adherence of the donor basic cornea to the recipient bed. Okay, now I'm putting in anterior chamber, ventana, right? And I always perform an inferior iridectomy to prevent basically pupillary block due to the air bubble after the surgery. And since this is DSEC, I'm creating 4 venting incision slits, right? So that I can basically remove the interface fluid to basically help adhesion of the cornea, right? This is a pre-cut basic donor cornea that I've got from the National Eye Bank in Singapore. So the cornea has already been cut. I'm just marking the edge of basically the anterior cap. I'm confining then the cornea up to the size that I want, separating basically the donor cornea into the anterior lamellar cap and the posterior lamellar basic graft that I want to use. Load the entire cornea onto basically the TUN endoglide. I apologize basically for the white out basic appearance because this is a white surface, so it's very hard to see. So I've removed the anterior cap, and all I have there is basically the posterior lamellar graft, which consists of a bit of stroma, and the donor's Descemet's membrane endothelium, and then now coiling the graft into the endoglide. Right, this is almost like basically IOL, basically loading and insertion. All right. Okay. So extending the 2.75 basic wound to 4.5, and then inserting basically the endoglide into the eye and pulling basically the graft through. This is always in the correct orientation, basically stroma side up, and then you put an air bubble to float the graft up, and then close the wound, right, with basically 2 or 3 basically tendon nylon stitches. Right. Reposition basically the donor graft by stroking basically the cornea on the surface, and then putting a full air fill to ensure complete adherence basically of the donor graft to basically the recipient bed. I'm now milking basically the fluid out of the incision, the venting incisions, and then closing the conjunctiva, followed by subconjunctival basic antibiotics and bandage contact lens. Okay, so this are steps of basic DMAC, which is very, very similar. I do it in a very similar fashion as DSEC. The only difference is that I stain basically the cornea, the donor basic endothelium with trypan blue and physically peel it off. I then fold it into basically almost like a taco and insert it into the TUN endoglide. I use the basic TUN DMAC endoglide, but there are other basic insertion systems that I can use. This one has an internal basic lumen diameter of 2.65, so you can just use a standard basic keratome to make a clear cornea incision, and then using the same pull-through technique, basically to pull basically the donor's Descemet's membrane into the recipient eye. And again, at the end of it, putting a full basic air fill. In this case, I tend to use basic FS6 instead of basic air because this basic Descemet's membrane has a high propensity of basically dislocating and falling off after the surgery compared to basic DSEC graft. So the advantages of basically doing endothelial keratoplasty, the vision recovery and visual outcomes are way superior basically endothelial keratoplasty compared to a penetrating keratoplasty. So you can see in this case where you have one eye done by DSEC and basically anterior segment OCT of a DSEC, and the DMAC graph basically that you can hardly even see basically the change in the corneal basically posterior corneal basic curvature after DMAC graph. Then also the rates of basic graft rejection is much reduced in basic endothelial keratoplasty compared to basic penetrating keratoplasty. So in the penetrating keratoplasty, I usually tell my patients that the risk of basic graft rejection is at least 20% lifelong. Whereas in the DSEC basic graft, the risk of rejection is about 10% or less. In the DMAC graft, it's usually less than 1 to 3%. So obviously it comes, endothelial keratoplasty has its own unique basic challenges and disadvantages. If you're a starting surgeon, basically the primary graft failure rate is a lot higher, and it's really dependent on, I think, the surgeon's experience and also how well basically the graft has been prepared pre-operatively. Graft dislocation is a unique complication in endothelial keratoplasty. You can see in the photos, basically double anterior chamber of a dislocated DSEC graft, and the anterior segment OCT photo showing basically the interface fluid and the detached DSEC graft, which you have to basically put in an air tamponade and reposition and reattach basically the detached graft. Other things can happen, pupillary block glaucoma, as you can see in this photograph, where basically the residual air bubble migrates into basically the posterior chamber and it causes pupil block. This can be usually prevented basically by creating a peripheral iridectomy inferiorly during your procedure. Interface haze epithelial ingrowth in DSEC. I have had basically the DSEC grafts falling and dislocating a posterior segment, say through an iris defect in a patient where basically there's aphakic. Cornea infections in the interface, endophthalmitis, and again, like anterior lamellar keratoplasty, you need customized equipment and instrumentation. And for DMAC, actually, the learning curve is really pretty steep. Okay, so this is schematically basically what we've gone through basically in the last like 50 minutes or so. What a penetrating keratoplasty, where we remove basically all the 5 layers basically of the cornea and replace it with a donor graft. Adult graft, where you basically remove all basically of the recipient's cornea up to the level basically of the Descemet's membrane. A DSEC graft, basically where you replace basically endothelium, Descemet's membrane with a little bit of basically stromal tissue. And the DMAC graft, where you really only transplant basically the Descemet's membrane and basically the cornea endothelium. This is actually an outdated slide, but this is data from our National Eye Bank in Singapore. You can see that when I started my training basically around the year of 2000, basically most of the grafts in light blue is still basically full thickness transplants or penetrating keratoplasty, and only about 18% of grafts are actually lamellar grafts. And by 2009, 2010, we have about a third of grafts being basically penetrating keratoplasty, a third of basically endothelial keratoplasty, and a third of basically anterior lamellar keratoplasties. Nowadays, I mean, I've looked at basically my recent data, less than 5% or less of my transplants are penetrating keratoplasty, and about 60 to 70% are endothelial keratoplasties, and remaining basically anterior lamellar keratoplasties. So basically the changes have basically the improvement in cornea instrumentation, imaging has really changed the practice basically of cornea transplant in basically a lot of cornea services around the world. So why change? Why not basically stick to basically doing a penetrating keratoplasty, which is quite simple to understand, quite easy to do, takes me about half an hour, 45 minutes usually. It's really because of the advantages of lamellar keratoplasty, where you can selectively remove just the diseased part of the cornea. You preserve the globe integrity. You no longer run the risk of open sky surgery, risks like basically suprachoroidal hemorrhage, expulsive hemorrhage intraoperatively. And really the reason is that the graft rejection rates are way, way lower in basically lamellar keratoplasties. I do not even basically put my patients on who have anterior lamellar keratoplasties on steroids for life. They usually receive steroids for about 6 months to 9 months, and then stop basically the topical immunosuppression after that. And all basically the graft rejections in lamellar, in anterior lamellar keratoplasties are reversible easily with just topical steroids. The visual outcomes basically in endothelial keratoplasties are definitely superior than penetrating keratoplasties. There are no suture-related basic complications in EK. And also basically when I'm doing anterior lamellar keratoplasty, I can have less rigid tissue criteria. I don't even need basically a PK grade cornea. I can have basically a frozen cornea and I just strip off basically the disused membrane endothelium of the donor that I do not use. So I can use potentially a lot of different types of tissue basically for my AL case. Globally, basically, the use of lamellar keratoplasty has increased, and there's an expanded indication basically for using lamellar keratoplasty. So some of us have actually used even basically adults in penetrating injuries, like in this case, a young foreign worker who sustained a penetrating injury to the eye, and also a traumatic cataract which was removed, and basically artificial lens was put in. But he was left with basically a visually significant scar across the visual axis, which I then did basically a manual deep anterior lamellar keratoplasty down to the level of the scar that you can see basically from the anterior segment OCT. So I removed not all the scar tissue, but most of the scar tissue, and regularized basically the anterior surface of the cornea topography, and such that basically the patient's basic vision can recover. And also because this is a young foreign worker who may not have access to basic good medical care when he goes back home, by doing adult, basically I spare him the need basically to use immunosuppressants basically in the eye for life. And also basically I feel that this is a safer surgery basically for the patient to have in the long term. Other users, we now use basically e-case to treat basically graft rejection in cases with previous penetrating keratoplasty. So instead of repeating a penetrating keratoplasty in eyes that have basically graft failure due to rejection, if basically pre-surgery, the PK graft has acceptable topography and a good basically outcome of the PK, and now we have basic graft failure due to rejection, all I do is then do basic anterior keratoplasty instead of basically putting whole graft off and repeating a PK graft, and basically increasing the risk of graft rejection by doing a repeat penetrating keratoplasty. Okay, so I've come to the end of basically my presentation. I would like to acknowledge my colleague, Dr. Charmaine Chai, for editing basically the videos, and basically welcome basically any questions that you may have for me that you can write down either in the chat or basically you can ask me in the Q&A section that I think it is coming up after this.
Thank you, Dr. Anna. That was a very great presentation and a very complete information about keratoplasty. Let us move now to the question and answer session. We have gathered all the questions from the audience through all the speakers. I will read the questions from the audience, and I will ask the question one to each speakers. Let me ask the speakers in bergantian. I'm sorry, from Dr. Lukman, Dr. Farabi, and also Dr. Anna. So we can have a blend discussion also, and perhaps Dr. Lukman and Dr. Farabi and also Dr. Anna can add some opinion about the discussion we will have from others' questions. First, I would like to ask Dr. Lukman, an audience have questions about How is the protocol and dosage of tacrolimus and anti-VEGF administration in LSCD cases? And how can we know the treatment works? Please.
Okay, thank you, Dr. Siska. So the protocol or and how we use the tacrolimus ointment, actually, unfortunately, that we don't have tacrolimus eye ointment in Indonesia, but we have tacrolimus ointment 0.03%. And then we can give patient with this ointment very thin in the eyelid, as usual. If you give the patient with the eye ointment, in the anti-VEGF itself, it is similar with the dosage of intravitreal anti-VEGF that we already have in our hospital. So can inject the anti-VEGF nearby the neovascularization, corneal neovascularization. And then how can we know that this treatment works? It's very important that if we see there is no or very small of neovascularization, and then the donor itself it's look like healthy. Okay, it's fresh and no necrosis, and then no infection. Yeah.
So in the clinically, we can see that the cornea getting better with the treatment.
Especially that we have prevent from the neovascularization.
And the neovascularization seems decrease. Okay, thank you, Dr. Lukman. And I would like to move to Dr. Farabi. There is a question, is there any possibilities of late onset detachment membrane detach more than 3 months post cataract surgery? And how is the management?
Thank you for the questions, Dr. Siska. Yes, of course, it is possibilities that there are late onset of this disseminate membrane detachment in several patients, like in the patient that already have endothelial dystrophy problems preoperatively, or the problem in the fibronectin. So the attachment of the disseminate membrane itself to the stroma is not strong enough. So the surgery is only the hanya pencetus, only the start, the trigger of that detachment. In several months later, he can get disseminate membrane detachment because of that underlying disease that he already have. The treatment is, like I say, we can still try to perform the surgical intervention like descematopexy. If it not work, it's better to change all the endothelial or perform the endothelial keratoplasty.
Okay. If I may, Dr. Anna, can I ask your opinion about these same questions? Dr. Farabi earlier have present a case of endothelial detachment, and there's a case of there's a blood in the pre-disseminate, and he removed it, and with air bubble, and the reattachment came again. And there is questions about what if there is a case of late endothelial detachment of late onset came to us 3 months after cataract surgery, let's say. What is your opinion about that? Dr. Anna, can you share with us?
I think I would agree basically that I would still put basically air tamponade to try to reattach basically the Deficiency membrane as far as possible. And sometimes it may have to be even repeated. So you can basically reattach it and can still fall off again. If let's say there's any partial success, I'll actually repeat basically the air tamponade to try to reattach the Deficiency membrane. And only if let's say it's like after they have intervened, let's say once or twice, and the Deficiency membrane keeps falling off, there's no non-resolution of the detachment, then I'll offer the patient endothelial keratoplasty. So my primary procedure of choice. Even if the patient presents late at 3 months after, let's say, cataract surgery, I will still basically perform pneumatic reattachment of the Deficiency membrane.
Okay, thank you, Dr. Anna. So I have one question from the audience for you. The audience asked about how is the post-operative management after penetrating keratoplasty or anterior lamellar keratoplasty. Is there any difference?
I think the post-surgery immunosuppressive regimen is actually very different. So in penetrating keratoplasties, I tend to start them on like 2 hourly, 3 hourly prednisolone 1%, and then gradually tapering. In fact, for the penetrating keratoplasties, I used to stop the steroids at about 5 years after the PK. Nowadays, I tend to keep them on very low dose, let's say fluorometalone once a day or once every other day for life. Whereas for deep anterior lamellar keratoplasty, I only use steroids for about 6 to 9 months, just topical steroids, and then I stop. I don't even continue them on steroids after that. And if the patient presents with rejections after that, stromal rejection, after you stop the steroids, it is really very easy reversible by using high dose topical steroids for a short while and then tapering off, and then I don't actually continue my patients without on topical steroids, usually beyond 9 months.
Okay, thank you, Dr. Anna. So basically with the penetrating keratoplasty, most of the time we need to continue a topical treatment and in the lamellar keratoplasty, we can stop it in the shorter time. Thank you. And I go back to Dr. Lukman. You have one question from the audience. How long is the maximal interval between corneal harvesting from cadaver to the implantation for the patient? Is there any suggestion of the minimum thickness of the limbal layer that can be used, and whether it will affect the success rate? Is there any other factor affecting the success rate? Did you get the question, Dr. Lukman?
Okay, thank you, Dr. Siska. So between corneal harvesting from cadaver to limbal stem cell graft. So usually we already prepare our patient with limbal stem cell deficiency as our eye bank. If there any patient plan to do the penetrating keratoplasty. So and then we have the remain of the donors. So we can call the patient to perform this limbal stem cell surgeries. So it means that how long, so it is similar with the optic keratoplasty. This is about 2 weeks with the optical. Yeah. And then the minimum of thickness of limbal layer is usually we just separate the donor, half of the thickness. And then we make a groove around the limbus on at the recipient. So and then we put the donor above this groove. And then, yeah, we suture with the nylon 10O. And then the success rate itself, yeah, mostly if the patient has no history of Stephen color burn, usually we will have the good result for this one. And then like a rosacea or maybe a patient with the history of conjunctivitis, chronic conjunctivitis or corneal ulcer. Yeah.
Okay, thank you, Dr. Lukman. Dr. Anna, do you have similar treatment or protocol or experience an LSCD treatment in your department? Would you like to share to us?
Usually, for unilateral limbal stem cell deficiency, I would harvest conjunctival limbal keratolimbal autograft from the healthy eye and then transplant it over instead of using the cadaveric. Or sometimes, if let's say instead of a localized limbal stem cell deficiency, where it's diffuse limbal stem cell deficiency in one eye, I sometimes use SLET, SLET, so I harvest about 2 clock hours of basically the healthy limbus of basically the fellow eye, cut it up into pieces, like 10 or 12 pieces, put it on the corneal surface after I debride basically the corneal surface of all the conjunctival basically vessels and panels, and then just put basically a drop of fibrin glue on top and put a bandage contact lens or a piece of magnetic membrane over. So that seems to do, that's quite easy to do. SLET is really a very simple procedure to do, and it gives very good results. I only use basically cadaveric transplants if, let's say, both eyes are involved, for instance, like, in Stevens-Johnson or chemical injury involving both eyes. And I also like to use actually living related, meaning that instead of getting a cadaveric basically donor, I'll ask basically the family members and basically harvest a small segment of basically healthy limbus from a relative, like one of the children. Yeah. So I find that that gives very good results, and I don't have to use a lot of immunosuppressants, immunosuppressive basic agents after basically doing a living related basic transplant as well.
Okay, thank you, Dr. Anna. And let me read one more question for you, Dr. Anna. Based on your experience, is there any difference on success rate of manual dog compared to dog with femtosecond? Is there any difference in success rate? Please, Dr. Anna.
I don't think there's really a difference in the success rate. It's just that, like if you can do manual basic dog is very dependent on the surgeon's basic skill. So the thing is that if you get to a pre-dissection plane and it's a smooth plane, right, the results will be good. And basically it's tougher to basically do a manual dog easily compared to using the femtosecond laser, where basically the plane of dissection is created for you by the femtosecond laser. But this is a very expensive way of basically doing a corneal transplant. So I don't think there's really a difference in result in the hands of an experienced surgeon. But basically for femtosecond basic dog, you really need expensive basic equipment. And I feel that really it's not worth the patient's money.
Yes, of course. Thank you, Dr. Anna. I have one more question for Dr. Farabi. This is regarding the technique of surgery that you show us on your video. This is how is to perform the venting incision in the correct position or in the correct layer to have succeeded in evacuating the fluid like you did in your video. Please, Dr. Farabi.
Thank you. Of course, ideally, we have to examine the patient with pachymetry first or anterior segment OCT before the surgery to have the information about how thickness is the central corneal stroma. And after that, in the intraoperatively, we do it in the center part of the the hemorrhagic detachment, because in that center part is the most deepest of the space. So we do not perforate the descemet membrane. But in this case, because we don't perform the anterior segment OCT preoperatively, we have to do it very carefully, and we step the apex or in the center of the HDD, and after we see the blood come out, we directly stop. So we have to make the quick and deliberate cuts, and not too deep cuts, just the superficially. As long as the blood came out, then the step incision is stopped, not too deep.
Okay, we have to find the place which the descemet is quite far from the place that we are going to do the venting incision first, and then we do it vertically, right?
I would like to just add on. So the most dependent, the deepest, where basically the diaphragm membrane is furthest away, basically, and there's the most detachment clinically when you examine, and also the most dependent part when the patient, let's say, sits up, right? So also usually inferiorly, you have to use a very sharp blade. I use a 0.5 millimeter diamond knife, all right, to do it. Basically, you apply basically the blade perpendicularly, basically the corneal surface, and once you see blood coming out, you stop, right? So you cannot basically, don't use basically a blunt, let's say, blade and then have been reusing again and again. You need to use a very sharp disposable blade or use a diamond knife.
Yes. Yeah, thank you, Dr. Anna. That is a very good point. I think we have running out of time. Thank you very much for all the speakers, Dr. Lukman, Dr. Farabi, and most of all, our distinguished friend, Dr. Anna Tan from NUH. Thank you very much for having us all and all of our audience. Thank you very much. I will close our morning session and we will continue with our second session. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Ini dokter Gangga dulu kan? Okay. Yeah. Greetings to all participants. Thank you for staying online with us. Soon, we will start our second session. In this session, two speakers will present their topic, and we will have Q&A session after the presentations. Before we proceed, I would like to remind you all, for those who are joining us using the YouTube Live, don't forget to register using the link that we provide on the chat box. I encourage all participants to write your questions in Q&A section, and also don't forget to fill the post test at the end of the session. The link will be given in the chat box, and make sure you fill it in order to receive your electronic certificate. Ladies and gentlemen, without further ado, we will invite now our first speaker in this second session, Dr. Gangga Trasuntar. It's an honor to have you, Dr. Gangga, here with us today. Dr. Gangga is one of the top international speakers and lecturers in orbit and oculoplasty surgery. He is the head of Orbit and Oculofacial Surgery Department of Ophthalmology in the National University Health System, also the senior consultant in Orbit and Oculofacial Surgery in the same institution, assistant professor, the core faculty residency program, and also the adjunct faculty Department of Pediatrics in the same institution. He is now the Deputy of Chief Examiner, Ophthalmology at American Medical Specialties in Singapore. And on top of that, he is now the President of the Singapore Society of Ophthalmoplastic and Reconstructive Surgery, the SSOPRS. Dr. Gangga Trasuntar, the time is yours, and thank you very much for presenting for us today.
Thank you. Thank you, Dr. Danielle. I really appreciate your kind words and introduction. I hope you can hear me.
Yes, we can hear you, Dr. Ganga.
And I'll try to share my screen. You have to activate my computer, I think. My PowerPoint is up. Okay, fine. Finally got it. Great. Thank you very much for your kind invitation. Lovely words. It's always great to meet friends, although it's online, and you all have done a wonderful job with this education initiative. I always appreciate people who go the extra mile on education. We are seeing opportunity within a crisis period. So I'm not going to give a very sophisticated talk like some of our previous speakers. I'm just going to give you a conceptual approach, a case-based presentation of ocular surface lesions. Acknowledgements, I work very closely with my anterior segment colleagues, Dr. Anna Tan, whom we heard, Dr. Ray, Prof. Donald Tan, when he used to be visiting us, he's an inspiration for creativity, and actually, more importantly, Prof. Chu. And why I mentioned that is he is the one who introduced me to my good friends in Jakarta and Cipto Mangun Kusumo Eye Hospital. And I remember visiting, if I remember right, in 2004, long time ago. And that relationship has bloomed over the years, and we have wonderful collaboration with contribution from all of our Indonesian colleagues, whom I would like to thank because they are very strong Asia-Pacific Ophthalmic Trauma Society members. I think you're probably the second largest member group within the Asia-Pacific Society. My good friends within the Oculoplasty community as well. We have a warm relationship with INA OPRS, and of course our people at Cipto and Jakarta Eye Center. So these are my disclosures. I'm a faculty for trauma for the AOCMF International. And of course, we do have a couple of publications, none of which has a direct conflict to the presentation today. So if we look at the ocular surface, what is the definition? We think it's a palpebral fissure area that we see between the upper and the lower eyelids, between the medial and the lateral canthus, as you see in the diagram over here. But what we forget to realize is that the ocular surface has direct implications because of the drainage mechanism from the lacrimal drainage system from up above, supratemporally, and also the surface, including the lid margin, that drains towards the punctum and the canalicles as well. So that's the true ocular surface for me. And if you go an extended perspective, you realize that the same ocular surface is directly or indirectly impacted by numerous mechanisms. Inflammatory diseases of the body elsewhere have manifestations in the eye. Likewise, any medications that you apply on the ocular surface, because of its drainage and absorption through the punctum, the canalicles, the nasal lacrimal duct, and the nasal mucosa, has systemized side effects as well. And it has great effects from the endocrine system, the immune system, oncological system, which I'll touch upon the last slide itself. And therefore, in summary for the beginner, what is the ocular surface? Not just the corneal surface, not just the bulbar conjunctiva that you see, but including the palpebral conjunctiva, the phoneal conjunctiva, the lid margin, and the mucosal lining of the proximal lacrimal drainage system. So technically, any pathology affecting over here is going to directly or indirectly going to affect the ocular surface and manifest either functionally or structurally, sometimes vision threatening, sometimes life threatening as well. So this is an outline of some of the conditions I'm going to touch upon in the next 15-20 minutes. I'm going to touch on some principles and concepts in congenital lesions, typically epibulbar dermoids. I'm not going to touch too much on trauma at this point of time in this presentation. That's a talk by itself. Give you a couple of newer perspectives on inflammations and allergies of the ocular surface. Again, I'm not going to touch about Stevens-Johnson syndrome. That's within the purview of you all. But the only reason why we oculoplastic surgeons come in is we need to desperately protect the cornea, doing medial lateral keratoplasties, tarsus refis if necessary, and we even do surgical punctal and canalicular closure in patients with severe dry eye disease. And of course, our next speaker who's going to talk to us about neoplasms. I'll just share a couple of interesting cases so that we have perspective on how a general ophthalmologist should see lesions of the ocular surface. And last but not importantly, I'm going to touch upon conjunctival chalasis. I think this is probably one of the most ignored, misdiagnosed, mismanaged condition before we touch on caruncular lesions. Let's talk about congenital conjunctival lesions. I put ocular melanocytosis here, which typically is seen in the differential diagnosis of pigmented ocular surface lesions, and we'll touch a little bit about it. And I'm going to touch a little bit about epibulbar dermoids. And remember that not all epibulbar dermoids are pure ocular surface lesions. They may have implications for the rest of the face, as you will see. So what are the common pigmentary lesions? Patients, oftentimes children especially, are brought to us by desperate parents who worried because they go online and find these dark spots in the conjunctiva, go Google it, and then find out that this could be a melanoma and a form of a cancer. So the most common form of pigmentation of the ocular surface that we see, which is not really on the conjunctiva but deeper within, are pigmentation emissary vessels. And that's where your role as an ophthalmologist comes in reassuring the parents that this is nothing but an anatomical variant. Because of the perforators that go into the sclera, into the uveal tract, you get pigmentation. And this sometimes can increase as the child grows up. And all the parents need is reassurance, there's no treatment necessary or easily done as well. We will touch on conjunctival nevis and melanomas later, but what should also be remembered is extensive pigmentation that, as you can see over here on the bottom right, about diffuse pigmentation of the upper, lower, perilimbal conjunctiva, sometimes even beyond. And what we're looking for is not just what's on the ocular surface that we see, but actually the eyelid and the facial surface. And that kind of gives you a diagnosis about what we're dealing with. And this has implications of whether the patient is Caucasian origin or Asian origin. Remember that sometimes these are aggressively diagnosed and managed as melanomas, and I'll show you some case examples later on. So going back to simple basics, variations of normal pigmentation of the emissary vessels to various forms of melanocytosis. So how about over here? If you look at this, this is something that we all see oftentimes, and there are different variations of it. The pure ocular melanocytosis. You can have ocular dermal melanocytosis. Why is this condition very important? Remember, it's just, again, not what you see on the surface, but what is deeper within. You can have significant pigmentary changes in the ipsilateral, not the contralateral choroid, the ciliary body, and the iris. And because of that, you have slightly increased malignant potential intraocularly. Hence, at least in the Caucasian population, these children should be seen literally every 6 months for the rest of their life, slightly different in our Asian perspective. Tumors can arise not only from inside the eye, but inside the orbit as well. They can have ipsilateral melanomas and other neural crest tumors. And not just within the orbit as well, you can have dural layer tumors in many of the meninges as well. So these patients ideally should be examined not just from the eye perspective, but from an orbital perspective and an intracranial perspective. And if these patients have had some kind of imaging, say an MRI ideally, at some stage of their life, you will realize that there are a lot of ipsilateral pathologies intracranial as well, which you should be keeping that in mind because they have potential tumor genesis capacities. And of course, it has been shown that about 4% of these patients who have the nevus of Ota, ocular dermal melanocytosis, have a risk of malignancy in their lifetime. So that's quite high. So that's where in that population, and you know, Indonesia has a high expat patient population, today is a global village. If you see a children, whether it's of Asian origin or a Caucasian origin, the follow-up is slightly different. And generally, it's good to see them on a regular basis. Of course, yet another thing to be kept in mind when you see this discoloration is a blue sclera, which is not very different from some of the previous pictures that you saw earlier on as well. And that's a sign of brittle bone disease, osteogenesis imperfecta. There's almost about 8 to 12 different types of it. Type 2 is the most severe, where children oftentimes succumb to the disease within the first 2 years of life. Why is, again, our awareness of this important? Because when you see them as babies, do not dissuade them and just say that this is a nevus or Ota, but actually refer them to a pediatrician or geneticist where mutations can be looked for, and these patients should be aggressively counseled and managed because the life expectancy is much lower than the average child itself. So just to showcase a spectrum of ocular surface pathologies, which all present similarly, but actually have significant implications life-wise. How about switching gears to chorostomas? These epibulbar dermoids that you all see, they can be simple ones or very complex ones as well. If you remember your medical school days, you read about the branchial arches, where the face is formed from the central process. Then you get the first lateral process, the second lateral process. A fusion in any defect, a fusion defect of anywhere in the first and the second branchial arches can result in some of those conditions that we see. So they can be either sporadic or genetic. With genetic, they're usually about autosomal dominant. Typical presentation is a limbal dermoid, which again is in the purview of the cornea specialist. And I'll just touch upon the principles of management, when to intervene, so on and so forth. But you should also remember that you can have epibulbar dermoids, which are lipodermoids, which are typically seen in the lateral part. You can see keratinizing changes right over here, as you can see my mouse. And you can see hair follicles and sebaceous glands as well over there. So that kind of gives you a giveaway that this is very different from the condition that we see in adults, which almost looks similar, but that's a prolapsed orbital fat. And that is managed very differently than if you would manage a lipodermoid. So here's a child who was referred to us. You can see the medial canthus is rounded, slightly abnormal. But if you look at the ocular surface, there's an inferotemporal epibulbar dermoid, lipodermoid. Now, where is the lateral canthal angle? Completely missing. So this is a variation of, and if you take an X-ray or a CT scan over here, even where the zygoma on the same side has not developed. Here's another patient who's had multiple surgeries for recurrent pterygium that you can see over here. And as ophthalmologists, sometimes we are notorious for switching off the room lights and looking only at the eyeball, but you want to look at the patient as he or she walks in. And then you realize that it's not just ocular surface deformity, but look at the entire face, the angle of the mouth, the nose. Then you realize that all these are variations of golden hour syndrome. Hence, screening these patients for these kind of syndromic disorders kind of gives you an idea, not what you see on the surface is all, but there might be more implications. And this will require genetic counseling and appropriate management. So how do we manage them? Limbal dermoids can be observed most oftentimes, unless there's a very high irregular astigmatism. And if and when you do excision, you have to consider doing a lamellar keratoplasty at the same time. It's not sufficient to just shave off, but you want to put a clear corneal graft on the surface. Angular lipodermoids oftentimes can be observed, but if you decide to excise it, remember the continuity, and it involves the ocular surface, the conjunctiva, so you can do a debulking or a conservative excision. As you can see in this child over here, where we have done that, and because there was absence of lateral canthus, we've gone on to do a lateral canthoplasty because the child had significant lag of thalmus and exposure keratopathy, following which the child has undergone aggressive amblyopia therapy. So a quick single slide on vascular malformations, a topic very close to my heart, because this is one of those few conditions which is still, in my opinion, poorly understood and poorly diagnosed, often misdiagnosed and poorly managed. So we now adopt the ISVA classification, which is the international study and the Society for Vascular Malformations, where basic classification as vascular lesions can be classified into tumors and malformations. For example, if you see the capillary hemangioma that we used to see of the eyelid in the orbit, they are now called infantile hemangiomas or congenital hemangiomas. Those are true tumors. Whereas if you look at the malformations, there can be lymphatic malformations. As you can see in this patient who has this almost cystic-like appearance on the surface, or as you can see in this patient where every time they have a URI, the conjunctival surface gets inflamed, settles down on its own, may require some topical steroids, that's about it. So these are conjunctival lymphatic malformation which can be observed, or they can have a slightly venous component. That's where the lymphovenous malformation comes in. And of course, you can have a pure venous malformation, which we actually increase with Valsalva maneuvers. Those are a little bit more challenging to treat, and that can be cautiously treated with intralesional sclerosing therapy. By the interest of time, I'll just move on. But just highlighting you how some of these conditions present. Quickly shifting gears towards inflammations, the most common ocular surface inflammation that general ophthalmologists, general pediatricians, adult general practitioners manage are allergies. And an aspect of an allergy that I think should be important and should be addressed is giant papillary conjunctivitis. You know, this can happen in chronic contact lens wearers, severe atopic allergic conjunctivitis, people even wearing prostheses, which are ill-fitting prostheses or scratched or not polished regularly, can have severe allergic conjunctivitis. So I'd like to show you a case report Dr. Ray and I wrote years ago of somebody who's had refractory, burnt out, massive GPC of the upper eyelid. She could not tolerate it with severe keratopathy and photosensitivity. So we had to surgically excise it and then treat it with amniotic membrane transplant graft over there. Of course, managing the underlying chronic allergies by which she had outgrown. She was a teenage girl at this point of time. And then you're able to return it. So bottom line take-home message in refractory burnt out disease where you've really gotten rid of the primary source of or the GPC, you may consider this form of intervention. Here's an example of patient, I'll tell you, who was referred to us. Again, maybe if the referring physician is listening to the talk, may recall this gentleman who had severe blepharospasm, could barely keep his eyes open because he was so sensitive to the light because of the lash ptosis that was rubbing against the cornea and severe keratopathy. When we looked at his eyes, as you can see over here, hardly had difficulty opening the eyes, severe form of allergic conjunctivitis, which caused a lash ptosis, keratopathy, which caused a secondary blepharospasm. So how do you break the cycle? So you have to aggressively treat the allergic conjunctivitis. Because he had developed the blepharospasm, which has become habitual, we ended up treating him with botulinum toxin injection after treating the aggressive allergic conjunctivitis. And because he had still persistent blepharospasms on a long-term basis and lash ptosis from the absence of lid crease, we ended up doing an eyelid surgery where part of the surgery was a limited orbicularis myomectomy, so the force of the spasm is not much, while we're tiding him the crisis through botulinum toxin injection in the periorbital area. Then you do a lash ptosis correction so that not only does he look good and handsome with the double eyelid, but more importantly, his ocular surface is much better, having treated the underlying predisposing condition, redirected the lashes away, so he's able to lead a relatively normal life. So just to showcase atypical forms of allergic conjunctivitis, where as an ocular plastic surgeon we play a role. So quickly jumping gears towards tearing, let me touch a little bit about it. We all know about tearing. The most common cause of tearing that we see in the average population is reflex tearing from either a secretory deficiency causing dry eyes or an evaporative excess causing dry eyes, or in patients who have lagophthalmus or other ocular surface disorders. Yes, we know all that. But then when you go, by the time it's referred to us, a lot of the times they refer to us for various forms of nasal lacrimal duct obstruction, which can be a primary acquired obstruction, which is the most common cause, idiopathic or inflammatory etiology, or very rarely a secondary acquired lacrimal drainage obstruction. And of course, having ruled that out, then you may want to start thinking about functional epiphora, where we see eyelid laxity, canthal malpositions, where we do lateral canthal surgeries. But why am I mentioning it over here? If you look at the bottom image over here, I'm not sure whether you see this right over here. You can see a little redundancy of conjunctiva at the lash margin. This is oftentimes overlooked by us all, including myself as ophthalmologist, as a significant cause of tearing. And this is conjunctival chalasis. Just as how you have age-related laxity of tissues from septum, from intermuscular septum, with prolapse of orbital fat, you can have laxity or weakness of the Tenon's capsule, which is supposed to keep the conjunctiva adherent to the ocular surface. And when that laxity takes over, then you have conjunctival chalasis. So clinical examination shows various degrees of conjunctival folds. Sometimes you may not see that in primary gaze. You may want to see them in down gaze or even lateral gaze, where you see various degrees of redundancy of the conjunctiva, and that can be a significant cause of tearing. It can vary from asymptomatic, where we don't have to do anything, to significant symptoms. And the very similar analogy is we have a carpet which kind of moves on the floor all the time. You can have carpet tags or something that secures the carpet so that you enter the carpet immobile. And that's exactly what we're trying to do in terms of management. And having ruled out other causes of tearing in these patients, you can resort to any of the forms of intervention, including a conjunctival excision alone, which can be done with a simple pinch technique, or you can do procedures where you can anchor the conjunctiva to the bulbar conjunctiva well below the limbus, or sometimes even in the fornix if you can. Sometimes I do fornix forming sutures. Or you have to remove a lot of redundant conjunctiva. You can do amniotic membrane transplantation. Or in the office, simply under topical anesthesia, you can even do superficial cautery to shrink the ocular surface so that you have redundant folds, and you have to do an adequate amount towards inferior fornix. So quickly shifting gears to the last two or three topics. Neoplasms can be, as you know very well, classified to benign, pre-malignant, and malignant. A classic example of benign, simple ones are cysts like these, which are very amenable to excision under topical anesthesia. The goal here is not to rupture the cyst, but to take it out intact, and then you can glue the conjunctiva together. Or sometimes you can have these cysts present as tumors of the eyelid or the orbit, when actually these are translucent conjunctival cysts. which can be managed easily with marsupialization. So conjunctival nevus, as you know, is common in our practice and sometimes can be challenging. And if you do not have enough patients to see and manage and operate, we can scare every patient with conjunctival nevus and say this can be a cancer and go take it out. In fact, if I remember right, in Singapore, the most common cause of indication on age group for removal of conjunctival nevus is the 18 to 19-year-old males. Do you know why? Because that's when they're doing the national service and they want to take an extra few days off, get a medical certificate in the guise of having surgery done. So conjunctival nevus is very common, but you have to remember that although these melanocytes are present at birth, typically they clinically manifest not at birth, but within the first several years of life, typically in the first to second decades. There are certain things which are known to increase rate of progression. Hence, you should not be alarmed into thinking these are malignancies. Hormonal changes, UV changes, sometimes medication changes taken for systemic conditions can also make them grow in size. And so you have to keep that in perspective before you say, oh my God, this is growing in size, we have to take it out, okay? One of the simplest way of diagnosing a conjunctival nevus and differentiating from something more sinister is looking at cysts. This is very similar to choroidal nevus that we sometimes see in the fundus, where again, you're seeing lesions within, like including the orange pigment that you would see over there sometimes, choroidal melanoma versus choroidal nevus. Likewise, a conjunctival nevus, you can pick up these cysts typically on slit lamp examination, reassure the patient, take a photograph, and with serial follow-up. So when should you, as surgeons, consider removing this conjunctival nevus? There's a beautiful review by Dr. Hanavar and Dr. Fairuz in Indian Journal of Ophthalmology, which gives you a specific criteria. For example, there's a new onset nevus in a 40, 50-year-old. Keep in mind, it's not typically in the palpebral fissure area or the bulbar conjunctiva, but a new onset lesion, as you can see in the picture over here, in the fornix or palpebral conjunctiva. Think of something sinister, including a melanoma. Remember, Asians are not completely protected from developing conjunctival or lid melanoma, so keep that in mind. Large lesions, anything growing significantly and larger in size, with a sudden increase in feeder supply to it as well, where the sentinel vessels are seen, where obviously, like I said, you don't see any cysts as well. And of course, they're extensive lesions, or they're tethered down to the deeper tissues. These are the ones which I think you should probably consider doing nevus excision. And of course, we in our practice and oculoplastic practice, except for maybe chalazion, we never throw any lid lesion, lacrimal lesion, any conjunctival lesion away. We always send it to the pathologist. So here's an example of a patient where there was an exuberant growth, and you can see increased vascularity. So is this a nevus or a melanoma? So when in doubt, that's where anterior segment OCT comes in, and you can do an OCT which tells you there's still cysts within. So remember, nevi can have cysts, can have even intrinsic vasculature that may look like a melanoma, but it's not a melanoma. All you have to do is reassure them. Of course, these are sometimes giant nevi. For cosmetic concerns, if it has to be removed, it can be removed, and with or without cryotherapy. So this is a conjunctival nevus where you can have the same features that we talked about. And indication for this removal is more cosmesis, not usually malignant transformation, although we can easily scare our patients and parents with it. So I'm going to end up in the last few slides introducing you to pre-malignant lesions, which our next speaker is going to talk about, Dr. Neni. She's an expert in the field. But remember that not all lesions are just either benign or malignant. There will be predisposing lesions. So to me, any pigmentation that was never seen before, was seen for the first time, and shown to be increasing in size, typically in the non-exposed bulbar conjunctiva, palpebral, fornical conjunctiva, are probably primary acquired melanosis. And if there's any documented progression, you should probably aim at excising them, doing a histopathological review. And there's now a new entity being described as melanoma in situ as well. So what are the spectrum of malignant tumors of the ocular surface? OSSN is going to be touched upon later, but I'm going to showcase a couple of examples of lymphoma and a Merkel cell carcinoma with their case scenarios, including the bottom right image is a multiple myeloma, a systemic disease presenting for the first time as an epibulbar tumor, which was treated with topical steroids for months before this patient was referred to us. Here are examples of two patients that you can see over here. If you look at This image over here, I don't know whether you can see my mouse, you can see there's a lashes rubbing against the eye. The first diagnosis that you would think of is an epiblepharon. It could have been a congenital or developmental feature, then should have been there for 30, 40 years, but she was never known to have it, okay? This lady was having recurrent epilations done with topical drops and steroids, so on and so forth, and this would not go away. This particular lady, all she ever felt was the lower part of the eyelid was full. And she was told that sometimes there's a variant of normal in young adults itself. And that's where you as clinicians come in, where telemedicine sometimes doesn't work. You literally have to put your finger on the patient and look into the fornices. What you see here is a significant, brilliant pink lesion going all the way to the medial canthus over here, a little bit on the other side. And if you look at this patient, when you put your finger over here, you can see a contrasting difference between the right inferior fornix to the left inferior fornix. So what's your diagnosis? And how do you make a diagnosis? You don't go around sending the patient referral to other physicians. You just do a simple under-topical anesthesia, a good size snip biopsy of these lesions, send them off to your pathologist who will come back with a diagnosis of a lymphoma. And conjunctival lymphoma is very different from an eyelid lymphoma, it's very different from an orbital lymphoma. Thankfully, most conjunctival lymphomas in non-immunosuppressed patients is a localized disease. Most patients with eyelid lymphomas have systemic disease, and half the patients with orbital lymphomas have systemic disease. So this patient can be either observed if they're minimally symptomatic. You just don't want to be treating with recurrent epilations. You want to treat the underlying disease. And when you meet the threshold for intervention, you can do external beam radiation therapy, which is the current evidence-based guideline. Or in patients who are not keen or you don't have EBRTs, you can consider intralesional interferons or intralesional rituximab. Sometimes we give this rituximab into lacrimal gland lymphomas as well. But of course, if they have systemic disease, the evidence seems to be pointing towards good effect of rituximab. Here's a gentleman again who was referred to us from elsewhere, who had had 4 or 5 different chalazion procedures. And none of the chalazions, when they started recurring, was ever sent for histopathological diagnosis. When we saw him, not only did he have an inflamed ocular surface, he had literally hard nodules in the conjunctiva. He even had a lymphadenopathy. Then the alarm bells go off. So this biopsy was done right in the office, again, and topical anesthesia, came back as a neuroendocrine tumor. And any of the youngsters there can think of what neuroendocrine tumors affect the ocular surface. This was a Merkel cell carcinoma. And because at presentation itself, he didn't have just an ocular surface issue, but he also had a cervical lymphadenopathy with a PET scan. And the PET scan shows not only ipsilateral cervical node involvement, he even had liver metastasis. At presentation, a stage 4 disease, very aggressive tumor, and despite the best of chemotherapy and radiation that was given to the local area, he passed away in 6 months. So remember, not all lesions that you see in the ocular surface are benign innocuous lesions. When in doubt, keep a high suspicion for atypical conditions, and you don't want to be the ophthalmologist who snips off lesion, keeps doing recurrent chalazion procedures, and not send these tissues for tissue diagnosis. A quick word on a new term which is coming into ocular plastics called onchoria. What is onchoria? Onchoria is a condition where it's now being shown, there's limited evidence, but it's evolving at this point of time, where ocular surface tumors, be it carcinomas, melanomas, or other tumors, can actually now start draining to the lacrimal drainage system, can lodge within the nasolacrimal duct, either from an underlying obstruction, pre-existing obstruction, or even otherwise, and can even present as lacrimal drainage system tumors. So what is the take-home message from this? When you're assessing a lot of these ocular surface tumors, do not forget the fact that the lacrimal drainage system is taking away the tumor cells elsewhere. So if you do imaging or the patient has significant tearing, try to assess and evaluate the lacrimal drainage system, because if you only manage the ocular surface, completely ignoring tumor cells within the lacrimal drainage system, you may actually miss the bus. So keep that in mind. Last slide on caruncular tumors. Remember, caruncle is part of the ocular surface. We didn't talk too much about it before. And those of you who are interested in embryology of the eye or believe in evolution, the caruncle is the third eyelid that you're supposed to have seen in younger, lower forms of animals. As you can see in this rooster over here, the little membrane that comes across. And what is interesting about the caruncle is it has of course, ectodermal origin, but it has epithelium both from the keratinizing epithelium like the skin and the non-keratinizing epithelium from the conjunctiva. So basically, any pathology that can arise from the conjunctiva can arise in the caruncle, and any pathology that can arise from the skin can arise in the caruncle, be they benign or malignant. So treat these caruncular lesions with respect. Here's a whole spectrum of lesions where you can have cysts, you can have granulomas, you can have adenomas, you can have papillomas. But remember, because they can have similar lesions as a conjunctiva in the skin, do not ignore the potential possibility of carcinoma in situ, or even a squamous cell carcinoma, or even a sebaceous gland carcinoma of the caruncle. So treat these caruncular lesions with respect. Don't just ignore them. Do a wide excision or incisional biopsy initially, follow it with appropriate treatment as indicated. So in summary, I'd like to wrap up saying that ocular surface disease is a lot of fun. So it gives you, makes you a complete ophthalmologist. It can cause significant morbidity, not from the visual loss, but from the life-threatening aspect as well. The spectrum is varied, and that's why I drive home to my residents. Never forget what you learned in medical school. Never forget what you learned in the residency year 1, year 2, because they sometimes say that is a part 1 question. Why are you asking me? I'm now an associate consultant or a consultant. Every little basic sciences, including anatomy, histology, and pathology, is very relevant for clinical practice. Have the appropriate, as a good clinician, a clinical suspicion. Try to make as accurate a diagnosis as possible clinically, and when necessary, do an incisional biopsy or imaging as an OCT so that you can make an appropriate diagnosis. Thank you very much. I bring you greetings from NUH Singapore. I know we have a very, very close relationship, and I'd like to invite you all to the first AP-Sopris webinar, of which you can recognize this face. She's the secretary of the International Ophthalmic Plastic Surgery Society, Dr. Shanti, who's joining us along with the stars of Asia Pacific Society. This is on the 18th of July, which is next weekend, I think. And I also invite you to a trauma webinar that we're doing, which is also on the 19th of July, which is brought to you on behalf of Asia Pacific Ophthalmic Trauma Society. And I'd like to thank you for the invitation and thank our Indonesian colleagues for the warm friendship we've had over the years. And most importantly, thanking you all. And I'd probably on behalf of Geeta and Unia, I'll invite you to our APOTS meeting we're going to be running in Bali in July 2021. Thank you very much. And I will stop sharing.
Thank you very much, Dr. Ganga, for your concise and interesting presentations. Okay, without further ado,
can you stop sharing for me because I can't do it?
Okay.
Yeah, you've done it. Thank you.
Yeah, thank you, Dr. Ganga. Now we will proceed to our next speaker. The next speaker will be Dr. Neni Anggraeni, Specialist Mata Konsultan from RSCM Kirana, Jakarta, Indonesia. She is the oncology consultant at the Department of Ophthalmology, Cipto Mangunkusumo, RSCM Kirana, Faculty of Medicine, Universitas Indonesia. She had a scholarship on ocular plastic and orbital disease fellowship in the Seirei Hamamatsu General Hospital, Hamamatsu, Japan. And she is also the member of Scientific Division of Indonesian Society of Ophthalmic Plastic and Reconstructive Surgery, INASORPS of the Perdami. And added to her resume, she is also one of the great cook in RSCM Kirana. Thank you, Dr. Neni. The stage is yours.
Okay. Yes. Okay. Thank you, Dr. Hisar. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. First of all, I would like to welcome our invited speakers from National University Hospital Singapore, Dr. Gangadhara Sundar and Dr. Anatan. Thank you for participating in today's webinar. And also, I would like to thank the committee for inviting me to share my experience in managing a patient with ocular surface tumor. I have no financial disclosure. Thank you, Dr. Nina, for some photos and some videos. Indonesia is located along the equatorial lines, which increase the risk of ocular problems due to constant sun exposure. This is one of the predisposing factors that Indonesian population are more prone to develop ocular surface tumor. Recent survey at our hospital as tertiary referral hospital revealed that ocular surface was the third most common location of malignancy after the orbit and the eyelid. Most ocular surface tumor cases are benign, but 30% of it were malignant. Compared to worldwide incidence of ocular surface tumor was only around 0 to 3 cases per 100,000 population. First, what is ocular surface tumor? Tumor that involving the cornea, the limbus, and also the conjunctiva. All of these three parts lined by non-keratinized stratified squamous cell epithelium. OSSN was the most common type of ocular surface tumor in our hospital, similar with the study by Nanji. And the majority cases, around 87%, of our patients were diagnosed as invasive squamous cell carcinoma, and most of them were at stage T2 or more at initial visit. How we approach a patient with neoplastic conjunctival lesion. First, we should take a detailed history taking. Is there any risk factors such as extensive sun exposure? Is there any smoking habits? And how about the gender? Male usually more frequent to have ocular surface tumor than female. And is there any previous skin cancer? Is it an HIV positive patient? Is there any human papilloma virus, hepatitis B or C infection, and XP, and also immunocompromised patient? And how about the onset? Is it rapidly progressive or slowly progressive? And how about, is there any changes in the lesion's appearance? And notice the ethnic background. Clinical signs that should be noticed are, is it single or multifocal? Is it pigmented or non-pigmented? And where is in the location of the tumor? And is there any corneal involvement? How about the consistency? Is it solid or cystic? Cystic usually defined as a benign lesion. Is it flat? Flat usually also a benign lesion and or elevated. And is it mobile or fixated to the underlying tissue or the sclera? And is there any feeder vessels? And don't forget to do the fundus examination for rule out the intraocular invasion, and do the regional lymph node to seek whether there is the metastasized to the regional lymph node, and also documentation. The ultrasound, biomicroscopic, and anterior segment OCT are very useful to evaluate the pre and post treatment. And of course, definitive diagnosis was made by histopathology examination. It is possible malignant if there is an elevated lesions and extensive pigmented lesion, even if flat, and lesion fixated to the underlying tissues, and lesion with a large feeder vessels. Ocular surface tumor can be classified as non-melanocytic or non-pigmented, and melanocytic or pigmented type. The non-melanocytic or non-pigmented type is what we call OSSN, or ocular surface squamous neoplasia. Both types consisted of 3 subtypes: a benign, pre-invasive or pre-malignant, and malignant. OSSN characteristic, usually a small lesion with no subjective symptoms, slightly elevated, relatively demarcated, and accompanying feeder vessels, and located usually in interpalpebral fissure. And if there is a corneal involvement or extension, usually circumscribed, and if it is diffuse, very often misdiagnosed as conjunctivitis. The benign type of OSSN includes squamous cell papilloma, which is the most common type. And as you can see here, is a very unique vascularity pattern of the papilloma. And then once you see, and then you will never forget. And the other type is hyperplasia and dyskeratosis, which is the less common. The pre-invasive OSSN is called conjunctival intraepithelial neoplasia, or CIN. This is the schematic histopathologic features of OSSN progression. The first panel is the normal tissue with normal epithelium and basement membrane. in chin or conjunctival intraepithelial neoplasia, a portion of epithelium is replaced by these plastic cells, and in carcinoma in situ is completely replacement of epithelium with intact basement membrane, and for invasive carcinoma, there is invasion through the basement membrane into the stroma. These are the various morphological type of chin. The leukoplakic chin, characterized by a whitish plaque, and then usually demarcated. And the papillomatous type, the gelatinous type, and if you can see here, a very thin layer on the cornea from the limbus invading the cornea. This is the superficial corneal invasion of chin. And the last one is the severe chin or carcinoma in situ. The malignant type is invasive squamous cell carcinoma. As I mentioned before, all the layer in the epithelium was already replaced by the dysplastic cells and invade through the basement membrane onto the stroma. And this is an aggressive tumor but has a low metastasized potential. And the less common type is mucoepidermoid carcinoma. This is the case of invasive squamous cell carcinoma. The second variant of melanocytic type, these are the benign type. This is the racial melanosis. Dr. De Gangadara already mentioned also, usually bilateral and congenital and flat, patchy, flat brown, non-cystic pigmentation. This is conjunctival nevus, usually discrete, and it has a cystic appearance. And the benign also primary acquired melanosis without atypia. This has a low risk of evolve into the malignant melanoma. And this is congenital ocular melanocytosis. The pre-malignant type from melanocytic type is the primary acquired melanosis with atypia. This has the risk for the transformation to malignant. And the malignant type is conjunctival malignant melanoma. The gold standard, because of non-invasive and invasive was made difficult to differentiate, so it should be treated as possible carcinoma. The gold standard is excisional biopsy with no touch excision, with wide margin around 4 to 6 millimeters, and cryotherapy usually now is considered as a gold standard also. And we can give a topical chemo as an adjuvant therapy to lower the recurrence rate. This is the surgery, the white excision with tumor-free margin with no touch technique, alcohol-assisted keratoepitelectomy if there's a corneal involvement, cryotherapy to resection edge and base. Sometimes we need to do the lamellar keratectomy and sclerectomy, and enucleation if there is invasion to the intraocular, and excenteration if there is an invasion to the orbit. This is the video of white excision. Incision marking around 4 to 6 millimeter from the visible tumor, and never touch the tumor lesion. Hold on to the normal conjunctival tissue. When the tumor is still there, avoid over irrigation. And then excise carefully along the marker using Westcott scissor or bipolar or monopolar cautery until it reaches the limbus. Then cut the corneal margin using the crescent knife. After we reach the limbus, then excise the limbal portion. Press firmly against the limbus to excise all the limbal tumor. If it's a Darren part, so 1/5 thickness sclerectomy should be carried out on this case. Alcohol-assisted keratoepitelectomy, we have to do it if there is a corneal involvement. First, we cut the cornea with crescent knife, and then apply MKA that already soaked into absolute alcohol for 30 to 40 seconds. And then excise the affected cornea using crescent knife first, and then peel the epithelial layer with using MKA. And then after that, we do the irrigation. The cryotherapy, the aim is to achieve minus 21 degree Celsius. We cryo over the conjunctival edge and the limbal sclera if it's involved also. And it should not more than 3 o'clock hours limbal area to avoid limbal stem cell deficiency. And we do it doubled, freeze-thaw technique. It will rupture the tumor membranes and occlude the blood vessels, so resulted in non-viable remaining tumor tissue. This will lower the recurrence rate 3 times. The defect closure depend on the size and the location. Use different instrument than the excision instrument, and then can be achieved by direct closure. We do the undermining, and then after that we suture the remaining conjunctiva to episclera at the limbus, and then suture the rest of conjunctiva to conjunctiva. If the defect is quite large, we can use conjunctival limbal graft and fresh amniotic membrane transplant and lip membrane graft. For corneal defect, we can use dried amniotic membrane, and then we suture with a nylon 10O, or you can use the glue, but in our hospital, there's no available. And for specimen handling, place the tumor tissue over the filter paper and leave it dry so it sticks to the paper, and then draw according to the proper anatomically orientation of the lesion, mark especially the one needed confirmation for tumor margin. This is the adjuvant therapy for SSN that are already available in all over the country, but unfortunately in Indonesia, we only have mitomycin C for adjuvant therapy, but there's also 5-fluorouracil, interferon alpha, 2B, cidofovir, and other such as PDT, brachytherapy, and anti-VEGF. This is studies about MMC either as primary and adjuvant treatment. And adjuvant topical mitomycin C reduced recurrence rate compared to the surgery alone. And these studies report the successful rate of 5-fluorouracil as primary and adjuvant treatment reach up to 80% resolution and around 10% recurrence rate. Interferon alpha 2B also showed a higher successful rate both as primary and adjuvant treatment. American Academy of Ophthalmology article mentioned about the efficacy is equal between for both medical and surgical treatment, and both groups showed similar quality of life. These are cases that we manage with excision and topical mitomycin C 0.04%, showing a good result. This is a recurrent conjunctival papilloma, a very big tumor in the limbus and also conjunctiva. This one is very like 3 or 2 quadrant, and we only debulk, but then afterwards we do the MMC topical, and then the result is quite good. And this is the invasive squamous cell carcinoma. And these cases of malignant melanoma we manage with excision and topical MMC, and is showing the good results. Thank you.
Oh, thank you, Dr. Neni, for your clear and interesting presentations also. So we will continue now to our Q&A session. Hopefully the Q&A session will be as interesting as well as the first session. So let me receive the list of the questions. Okay, Dr. Ganga, you are here with us now. Can you hear my voice clearly?
Yes, I can. Go ahead, please. Yeah.
We have several questions here. Show that our presentations, our session today is very interesting. The first question is for Dr. Ganga. In ocular surface tumor or mass, when do you perform the X-ray examinations? Your opinion, Dr. Ganga.
Well, of course, mentally you're trying to form a differential diagnosis of whether there's probably a benign lesion or a not so benign lesion. So in most patients who have benign lesion, who are well circumscribed lesions, typically cysts, single cysts if necessary, or they don't have any overlying ulceration, excessive blood flow, or so on and so forth, then you don't have to be worried about it. Then you go ahead with a simple excision. Having said that, when you extrapolate what we see in the ocular adnexal region of the skin, sometimes very benign appearing lesions can be malignant as well. So when you have the margin of error, always remove lesions with a cuff of normal tissue, because conjunctiva and tenons are quite forgiving, especially in younger patients as well. And try not to do a rupture of the lesion that you do. And even in benign lesions, I strongly would urge a no-touch technique. In terms of systemic evaluation, coming to your point, that's where your regional examination, whether you're able to see the posterior extent of the lesion that is presenting to you, is very important, and how young or how old the patient is. Any new lesion that is in a middle-aged to elderly patient should always be viewed with suspicion. Look for regional lymph nodes, preauricular, sublingual, submental, cervical lymphadenopathy as well. And when you're suspecting conditions like lymphomas, carcinomas, whether it's sebaceous gland carcinoma or Merkel cell carcinoma, by default, we now think that systemic, not just clinical examination, but imaging examination, be it a CT scan, MRI of the head and neck and elsewhere the body, or if you can, do a PET scan is very important. PET scan is useful for all the carcinomas for screening for systemic diseases, not very useful for all lymphomas because the enhancement can be varied from one type of lymphoma, a benign lymphoma like a Malt lymphoma, to a malignant form of lymphoma. I hope that answers your question.
Okay. Thank you, Dr. Ganga, for your answers. So the next question will be to Dr. Neni. The question will be, considering to the complications of topical chemotherapy, which ocular surface tumor requires topical chemotherapy? And if we don't have the facility with cryotherapy, what is the best treatment modality for ocular surface tumor, doctor?
Okay, the first one, which ocular surface tumor requires topical chemo? Okay, as I mentioned in my presentation earlier, the topical chemo is an adjuvant treatment for malignant, especially malignant tumor, but we can also use for the pre-malignant or benign tumor like SSN, which already recurred. So if it's only the first time that we excise the tumor, then you don't need to give the topical chemo because it's very, quite expensive here in Indonesia, and not so available in other facilities than in institution hospital. It's very hard to get it. So if it's the first time, you don't need to do the adjuvant treatment. But if it's malignant, yeah, better you give the adjuvant chemotherapy. But if pre-malignant benign, but it's already recurrent, like 3 or 4 times, usually I give the mitomycin C topical. And as we know, the MMC topical also had side effects, like very irritating to the ocular surface. So we have to very careful to give the indication, and especially if the margin is positive and the tumor is malignant. So we should give the adjuvant treatment for chemo. And the second one.
What is the best treatment modality for ocular surface tumor if you don't have the access to cryotherapy?
Oh, yeah. Well, if you do the surgery with no touch technique very thoroughly and very carefully, and you didn't touch the tumor at the second time, sorry. Yeah, so you can just do the very thoroughly operation with no touch technique and with a wide margin around 4 to 6 millimeters. Then I think it's suitable for the ocular surface tumor if you don't have the cryo. But then if it's already recurrent, then probably you should refer the patient to the facilities who has the better facilities, like adjuvant treatment like chemo.
So basically, the no-touch technique surgery is doable in third facility, not in first facility, in RSUD, so they can perform the no-touch technique.
Yes.
But the mainstay is still you have to consult this to pathology, right?
Yeah.
Okay.
Yeah.
Okay, Dr. Ganga, do you have any opinions about these questions, Dr. Ganga?
In fact, I just noticed one of my good friends, Dr. Delfitri Lutfi, is online. Are you able to allow her to speak on this? She's just finished a fellowship with Professor Arun Singh from Cleveland Clinic. Is that possible? Yeah. I know she's logged in.
Yes, it's possible. Dr.
Yeah,
Delphi,
meanwhile, hi, Delphi, go ahead. Give us expert input.
No. I just and hi, Dr. Manny. Well, I'm sorry. I just want to ask you about the chemotherapy topic because, well, there is a several option there, and then in your opinion, because I saw in US now Prof. Arun is using interferon more. I mean, they have like a complication, but he said that it's more like a give benefit to the patient. So what about your opinion here? Because we have limited access to some of this medication also. And also the drugs, I mean the dose for the medication also. What do you think about it? What dose that you use for your patient here? Thank you.
Right. Is Dr. Anna still logged in?
Anatan? I think it's not Dr. Ganga.
Yeah, so actually I work with Dr. Ray and Dr. Anna from Ocular Surface Neoplasm. So over the years, I have not managed them as much aggressively. Right, Dr. Neni, I just saw on your slides, nice columns of mitomycin C, 5-FU, interferon, and you had mentioned something else. And you said mitomycin C is available, correct?
Yes, here.
And 5-FU is not available?
No.
No, actually, they are readily available by your fellow oncologists. Actually, they routinely use it for systemic neoplasms, colonic cancers, GI cancers, and all that. In my opinion, 5FU is one of the cheapest drugs that you can find, which can be easily constituted, can be utilized as well. So I think, 5FU and corticosteroids are bread and butter for us oculoplastic surgeons in managing post-traumatic scars of the eyelids and the face and contracted sockets. So they are very cheap, very readily available, and you should be able to access it from your fellow oncologists, if not for the old-fashioned glaucoma surgeons as well. So I think that's very important. Interferon, the challenge Delphi, the problem is it's quite expensive, I'm told. The
Yes.
shelf life is very short. And even if patients are coming to us from overseas, which is where we don't see as much OSSN here from within Singapore, because our patients for some reason don't spend so much time in the sun. Whereas South Asia and Indonesia, where most of the people are out in the sun, that's where you see them a lot. So constituting them on a fresh basis, on a regular basis, and getting it across to our patients overseas has been a bit of a challenge. Dr. Ray, is he around? No. Or Anna, then they can add more as well.
How about the dose, Dr. Ganga?
Which interferons?
The 5FU or MUC.
Like I said, I don't manage this myself. If Dr. Ray or Anna are around, I'll probably let them comment here.
Oh, okay. Thank you.
And touching about cryotherapy, I think one of your colleagues was asking, if you're in a full-fledged ophthalmic practice, your retina colleagues should be using a cryotherapy machine all the time. And again, it's a very, very old 70-year-old or 60, 70-year-old technology, which you should be able to borrow. So a lot of things in oncology and oculoplastics is borrowed from your friends and neighbors in medicine. So you should be able to find it. Thank you.
Okay. Yeah, thank you, Dr. Ganga. Thank you, Dr. Delfitri. So we continue to next questions. To Dr. Nani, and also maybe Dr. Ganga can give us some explanations according to this question. In a tumor mass post-cryotherapy tumor mass, can it still be used for pathological examination, considering tumor cells might have been damaged due to low temperature?
Well, you do the cryotherapy at the edge, at the resting conjunctiva. It's not the conjunctiva at the tumor excision, the tumor site.
Mm-hmm.
So after you excise the margin, the cryotherapy you do at the conjunctiva, the edge of the conjunctiva, and also at the limbus and the scleral, if the limbus and the scleral is involved. Not the conjunctiva that we excise along with the tumor. So the tumor is, we don't disrupt any other parts, any parts of the tumor. We only hold on to the normal conjunctiva that we cut along with the tumor. Yeah.
And the tissue, can it still be used for, after you cryotherapy the conjunctival tissue, can it still be used for pathological examination, Dr. Nani?
The rest of the resting conjunctiva or the conjunctiva with the tumor? With the tumor. Even though you have to after you cryotherapy, you can still use it. Okay. But then the conjunctiva that we cut with the tumor, we don't cryo. Yeah. At that site. So the pathology cells is we didn't interrupt or disrupt anything. Okay. Dr. Ganga, any opinions?
Yeah, I agree. I mean, Dr. Nani, you don't do cryotherapy to tumor that you're excising. You're doing cryotherapy to the margins, which is left behind after you have removed the primary tumor with a no-touch technique. We adopt the same principle not just for OSSNs, but even for sebaceous gland carcinomas, so the eyelids, where you have given 4 millimeter, 5 millimeter, whatever margin you've given. It's a residual bed where, number one, you cannot do a frozen section. Where you still suspicious there might be pathology, you will do a double freeze thaw technique without allowing for spontaneous thawing not using saline to hasten the thawing process.
Thank you, Dr. Ganga, for the answer. So questions to our both resource person today. A short and brief answer, perhaps. There is a question from the audience, from the participant. Whenever we operate or perform a surgery in ocular surface malignancy, do you have any tips and tricks to ensure that our surgical margin is clear without sacrificing too much conjunctiva and limbal tissue? Short and brief, Dr. Neni.
Well, first we have to identify the tumor. Usually the tumor is there are parts that are very sharp edge, but then there's still dispersed cells that along with the center of the tumor. So we have to first identify the tumor site, and then we do the 4 millimeter margin from that side. So if there is like a little bit fleshy or pink vascularity after the tumor, then we also consider that that vascularity is also involved in the there's a tumor there. So we measure the 4 millimeter, not from the tumor, but then on the vascularity near the tumor, starting from that point. So we make sure that no the one that we cut is a normal tissue. Yeah. So it will be it will come with a good result usually. Then in the limbal, sometimes we cannot make sure that there's 100% already cut. So that's why the cryotherapy is needed. Because the limbus, we know that there's a higher vascularity there. So if the tumor is not completely removed, then the possibility for recurrence is high.
Thank you, Dr. Neni. Dr. Ganga?
I think it comes down to proper clinical examination of the slit lamp, differentiating normal from abnormal tissues. There are situations where additional stains will come in handy, like rose Bengal stain, that will again tell you the extent of normal versus abnormal tissue. But there is no OCT, which is now being described for both ocular surface and anterior segment invasion to figure out whether it's a pure ocular surface has penetrated the superficial cornea or superficial sclera, or truly intraocular as well. These are all conditions where in the past were untreatable, but nowadays with the advent of plaque brachytherapies, a lot of this is becoming very treatable conditions. So clinical examination, judgment, ancillary investigations, and then management.
Okay, Dr. Ganga, thank you for your explanations. Very short, brief, and concise also. So, dear participants, we now reach the end of our last session. We are sorry if we are unable to answer all the questions due to the limited of time. Thank you very much for all the speakers, Dr. Ganga Darasudar and Dr. Neni. Thank you for your willingness to share with us and also your time and expertise to all of us. And to all of our participants, we will close the post-test link exactly 30 minutes after we close our today's series. Yang terhormat seluruh peserta webinar, demikian acara ilmiah RSCM Kirana-NUH Collaborative Webinar Series pada hari ini. Terima kasih untuk seluruh peserta yang telah berpartisipasi. Thank you very much for our distinguished speakers, Dr. Ganga Darasudar and Dr. Anatan, for the lectures and the Q&A sessions. Also, thank you to all attendees from the National University Hospital and our fellow ophthalmologists in other countries. Terima kasih pula kami ucapkan kepada PT Sendo Pharmaceuticals dan PT Afina Sinar Cemerlang yang telah mendukung berjalannya acara hari ini. Hadirin sekalian, thank you Dr. Ganga.
Thank you.
Hadirin sekalian, kami juga ingin menyampaikan bahwa saat ini sedang berlangsung webinar Perdami Banten bekerjasama dengan NUH dengan pembicara-pembicara dari RSCM Kirana FKUI. yaitu Profesor Ratna Sitompul, spesialis mata konsultan, Dr. Rina Ladisianora, spesialis mata konsultan, dan Dr. Julia Aziza, spesialis mata konsultan. Dan kemudian juga kami mengingatkan bahwa Perdami akan mengadakan Perdami Virtual Scientific Meeting pada tanggal 18 sampai dengan 27 September 2020. Jadi kami undang kepada seluruh sejawat kita semua untuk mengirimkan abstrak untuk ikut serta dalam berpartisipasi aktif dalam acara tersebut. Dan terakhir kami undang hadirin sekalian semua untuk hadir kembali pada seri ketiga dari Webinar Series yang akan diadakan pada hari Minggu, tanggal 19 Juli 2020, dimulai pada waktu yang sama juga, yaitu 9 pagi waktu Indonesia bagian Barat. Dan registrasi dapat dilakukan melalui tautan yang akan kami sebarkan di media sosial, baik grup chat maupun Instagram @RSCM Kirana. Sekali lagi, @RSCM Kirana. Selamat siang. Wassalamualaikum warahmatullahi wabarakatuh.